Anyone who stops learning is old, whether at 20 or 80. Anyone who keeps learning stays young. The greatest thing in life is to keep your mind young. With these positive words, I would like to wish you a very good morning to all the dignitaries, our resource persons, dear all the participants from various colleges. I, Ms. Neha Parmar, Assistant Professor and Organizing Secretary of this e-conference, extends to you a very warm and healthy, hearty welcome to each one of you present here on a virtual mode in the spiritual center of Nadiyad City, behalf of BPCN family. I again welcome you all in the e-conference on exploring the advanced practices in maternity. I again welcome Professor Virendra Jain sir, Principal of Dinsha Patel College of Nursing, HOD Mrs. Dara Vyas Madam, Mr. Kailash Nagar sir, HOD of Community Health Nursing Department, in the e-conference on exploring the advanced practices in maternity under the IQAC and OBG department. I am also wonderstruck with the huge response from all the delegates from the overseas like Nepal, Australia, Canada, and different states like Meghalaya, Karnataka, Rajasthan, Madhya Pradesh, Maharashtra, etc. We got total 750 plus registration in this e-conference, and it's a huge number. We are deeply honored to have you today. To enlighten our spirits and receive the blessing, I request technical committee to create a peaceful atmosphere with the prayers. Now I request Dinsha Patel, Assistant Professor, Dinsha Patel College of Nursing and Department of OBP, to do the floral welcome of our Principal Sir, Professor Virendra Jain. Thank you, sir. Thank you, madam. Now proceeding towards the function, Shubham Karoti Kalyanam, Arogya Dhana Sampada, Shastra Buddhi Vinashaya, Deepa Jyoti Namostute. Now let us proceed further for deep pragatya. For this, I request all the dignitaries on the dais to come forward and light the inaugural lamp. Thank you, sir. Thank you, madam. Now, proceeding towards the function, let us have the listening welcome remarks of our principal, Professor Virendra Jain, sir. So I request sir to take a charge to address the dignitaries and welcome our eminent resource person of today's occasion. Please, sir.
Thank you, Ms. Neha Madam, Organizing Secretary of this conference. Good morning, all of you, and Jai Maharaj. On behalf of Dinsha Patel College of Nursing, I heartily welcome all the participants, faculties, and YouTube viewers for registering and joining this e-conference, which is organized by IQAC and Department of Obstetric and Gynecology Nursing on exploring the advanced practices in maternity. I am delighted to see all my colleagues, senior professor, research scholar, and dear delegates from Gujarat and all over India and overseas at this wonderful digital platform. I especially welcome Dr. B. Shelit, sir, director of our institute. I thank you, sir, for giving this wonderful thought to conduct e-conference in midwifery nursing field. I welcome you, sir. I, on behalf of Dinsha Patel College of Nursing, it is my great pleasure and honor to extend a warm welcome of galaxy of all respected resource person. I welcome Mrs. Ami Menon, Madam, Class 2 Lecturer, Government College of Nursing, Ahmedabad. I warm welcome Mr. Himanshu Vyas, sir, Associate Professor, College of Nursing, AIMS, Jodhpur, Rajasthan. I also welcome Mrs. Martha Raut, Madam, Associate Professor, Dr. D.Y. Patil College of Nursing, Pune. I warm welcome Dr. Mansi Chaudhary, Madam, Associate Professor, SAMS College of Nursing, Indore. I am very thankful to all the resource persons for accepting our invitation as a speaker. I welcome all faculty of Dinsha Patel College of Nursing and faculties from various rapid institutions for joining this conference. My hearty welcome to all dear delegates from all over India and overseas who have shown their interest to attend this conference. I am very glad to inform you that we have received total more than 750 plus registrations in this conference. We are very thankful to you all. I am very sure today we will expand the full of knowledge regarding the explore the advanced practices in maternity field. Once again, I congratulate to IQSC and Obstetric and Gynecological Department for organizing this virtual conference. Once again, I welcome you all. Have a great day. Thank you. Over to you, Ms. Neha Madam.
Thank you, sir. We all know that good things come to an end, so it's the same for inaugural ceremony too. So here I would like to thank our Director of DPCN, Dr. V.S. Shala sir, for his valuable suggestion and free hands towards us for the success of the e-conference. Thank you, sir. I also feel gratitude to our Principal, Professor Virendra Jain sir, for his continuous support and micro-planning of this e-conference. Thank you, sir. I also feel delighted to thank our Vice Principal, Mrs. Arpita Vaidya ma'am, for her remarkable contribution towards the success of e-conference. Thank you, madam. I also extend my gratitude to OBG department members, faculties, technical committee, Mr. Kailash Nagar, Mr. Chinmay Bhai Patel, Joshi, IT manager DPCN, Mr. Neeral Patel, and non-teaching staff, and dear all the participants for your continuous support. Thank you so much. Now, I take this opportunity to announce the inauguration ceremony of the conference is over. Now we begin with the first lecture of scientific session. For that, I hand over the charge to Mrs. Dhara Vyas ma'am, HOD of Child Health Nursing Department. Within few minutes, we are going to start our first session. Thank you all of you.
Thank you, Ms. Neha. Good morning to Ami Madam. Are you there?
Yeah. Good morning, Ms. Sarah.
Good morning, respected dignitaries and delegates. I, Dhara Vyas, Associate Professor and HOD of Child Health Nursing Department at DPCN, Dinsha Patel College of Nursing, welcomes you all in this conference on exploring the advanced practice in maternity organized by IQSC and OBG department. In OBG, antenatal care to care To care pregnant mother is very important. Pregnancy is a state of carrying and developing the embryo or a fetus. The diagnosis of pregnancy requires a multifaceted approach using the three main diagnostic tools: history and physical examination, hormonal studies, and ultrasound. The session is regarding advanced diagnostic modalities of pregnancy. To enhance our knowledge in this topic, we are glad to have an eminent personality in a nursing profession who may be the role model for many nursing personas, and that is Mrs. Ami Menon, Madam. Before Madam comment her expert talk, we will have some glimpse of her career in nursing profession. Madam has completed BSc Nursing in 1998 and MSc Nursing in OBG specialty in 2011 from Government College of Nursing, Ahmedabad. Madam has a huge experience in a nursing profession, 8 years of experience in a clinical side for various designation at the various hospitals. Also, Madam has a 12 years of teaching experience at a private and government colleges. Madam currently working as a lecturer class 2 at Government Institute of Nursing Education and Research, Geneva. Madam is very confident, hardworking, peaceful, and high-ranking influential administrator with the excellent communication skill. Madam has a great skill for the time management and work priority. Madam has delighted many conferences and workshops as a resource person. Madam has published many research papers in a national and international journals. Kind, honest, and humble. We feel very blessed with your presence, ma'am. Now I request ma'am for the expert talk.
Thank you, Ms. Dara. Am I audible?
Yes, ma'am.
Okay. Thank you so much for the warm welcome. First of all, I would like to clarify that I am a nurse by profession and a teacher by choice. So teaching is like what comes very naturally and a passion for me. So as an OBG faculty, I would like to thank Dinsha Patel College of Nursing for organizing this wonderful e-conference, which is a very huge task. A very warm good morning to one and all present here through this medium to attend this e-conference. Specifically, I would like to say about Professor Virendra Jain, the principal of Dinsha Patel College of Nursing, Mrs. Neha Perma, who is the assistant professor and HOD of OBG department, and I think who is the moderator and organizing chairman of today's session, today's e-conference, and all the dear participants from the different colleges, the nursing educators and clinical nurses and nursing students who came forward for this e-conference. So as Ms. Dhara said that the pregnancy is a very, very important aspect in the life of the mother. And it's not only the life of the women, but it is again associated with the social, like a good pregnancy can lead to a good outcome, that is a healthy newborn and baby. So moving towards today's session, first of all, I would like to share my PPT. Is it visible to everyone? Is
Yes,
it visible? Yeah. Okay. I just kept it on a presentation mode. Is it visible?
Yes, ma'am. Visible, but slides.
Yes, ma'am.
Yeah. Thank you so much. As today's session is regarding the advanced diagnostic modalities of pregnancy, some of those traditional methods and some of the other new modalities of pregnancy that we are going to discuss and we are going to see on today's session.
Madam, please do the slideshow. Madam, please
Yeah.
do the slideshow.
I just kept on a slideshow only. I just kept it on a set.
Unshare and share again.
Okay, let me see it. Is it okay?
Yes, perfect.
Yeah, thank you so much. So the objective for today's session is that at the end of the sessions, all the participants will be able to explain the need of the various diagnostic modalities of pregnancy. And again, we'll be able to list out the various advanced diagnostic modalities of the pregnancy and discuss the various advanced diagnostic modalities of the pregnancy. Now, giving birth should be the greatest joy, not the fear. As it is like being pregnant and giving birth to the baby is one of the greatest moments for the women, and it should bring a greatest joy to the woman, not the fear. Okay, so how we can help her to attain and to get this greatest joy is that providing a good prenatal and antenatal care during the pregnancy and thus the fetal outcome, thus keeping her baby healthy so that when at the end of the pregnancy, when she will deliver her baby, the baby will be definitely healthy and the mother will have a greatest experience of childbirth and the joy. As we all know that the life of a mother is the life of the child. If the woman is the mother, the potential mother, if she is healthy, definitely the health of the child also will be healthy. So it is very much important that a pregnant lady, or even before becoming a pregnant, a woman, she should be healthy enough to carry a healthy child and to deliver a healthy child. So the preconception care, again, it is very, very important part of the antenatal care and the positive childbirth experiences. Before moving towards the antenatal care, first we would like to see about the prenatal care because it is again very, very important factor which will be affecting the pregnancy. Now, what is prenatal care? That is the comprehensive antenatal care program which involves the coordinated approach of the medical care and psychosocial support that optimally begins before the conception and extend throughout the antenatal period. So before the conception itself, the women and her partner, they should be given proper medical care, they should be given a psychosocial support, they should be counseled so that when they will the women get pregnant, so at that time definitely there won't be any complications and the pregnancy will move smoothly forward and the outcome of the pregnancy will be a pleasant one. So that's why the prenatal care is important. Okay. Now, what are the prenatal counseling, like preconceptional counseling? So, first of all, the provision of biomedical, behavioral, and social health intervention to women and couples before the conception occurs. Like, suppose the couples, if anyone is having any genetic disorders or any chromosomal anomalies or family history of any genetic or chromosomal anomalies or the previous obstetric history of any this type of complications, then definitely they should be given that biomedical provisions. So if any of the infections or any of the problem is there, that should be corrected. Very simple example is that the woman had German measles. Okay, so rubella. If she had rubella and due to that she lost her previous pregnancy, then definitely that should be corrected. She should be vaccinated, and after that she should be advised for future conception. So that should be done. The behavioral and social health intervention, whatever the behavioral and social health intervention that is needed to the women and her partner. Okay, which type of the behavioral modification they should be done to maintain an optimum health. Okay, so like if they are having any bad habits like smoking or any drinking habits or any tobacco chewing habits uh, among the women and her partner. So that type of behaviors that also should be addressed. And social health intervention. Now, pregnancy is like it is a very big issue to the women and her partner. So when the women becoming a parent is a very major responsibility, and whether the women and her partner, they are ready to become a parent, they are ready to accept that uh, ready to accept that responsibility. And if they are ready mentally to accept that responsibility, not only mentally, but even socially and economically, if they are ready to accept that responsibility, then only they will be able to provide a better care to their offspring, to their child, and the child will be healthy. Okay, so that is again very important aspect, and then aims to improve their health status and reduce the behaviors and individual and environmental factors which are contributing to the poor maternal and child health outcomes. Okay, now the health status that should be improved if the woman is anemic, or she is having any other type of health, like she is malnourished, low weight women's is, or any type of diseases is there. So that's all, not only the women and her partner even, so that all should be addressed. Okay, the behaviors, reduce the behaviors, like I already said, the behaviors according to, if they are having any unhealthy behavior, so that also should be reduced. And the environmental factors, that also very very important, like individual, not only environmental only, the environmental is regarding the whole occupational and all. If the person is very stressed out, if they are having so much stress and all, that is going to affect their hormones, and that will be again going to affect the fertility of the women. Okay, and these all may lead to a poor maternal and child health outcomes, so that also should be addressed. So once the women and her partner mentally, physically, or and socially, they are ready to becoming a parent, then only the conception should occur. So that is the main aim of the preconceptional counseling. Then ultimate aim is to improve the maternal and child health in both short and long term. Okay, so short term, during the antenatal period and intranatal period and postnatal period, the child health, that also the good child health that we want, and not only child health, the maternal health, and in the long term period. Okay, so if the baby won't be having any congenital abnormalities, won't be having any complications, a good, if the baby is delivered at term, without any complications, and the birth weight is normal, and the proper neonatal care, and during the infancy the proper care will be provided, then definitely a great child, or we can say healthy child, that will be uh, the healthy child can be raised, and that will be a contributing factor to the country. So that is very much important, that through this preconceptional care, the maternal and child health outcome, or their health, we have to improve. And in again in that the family planning counseling, that also comes, like if the women and partner, they had already a child, so minimum 3 years of gap that should be kept between two childs, so that the mother's health and the child's health both cannot be compromised. So these all things that we have to see during the preconceptional counseling. Again, the genetic counseling that we can provide to the women and her partner who is having any type of, like I said, chromosomal or genetic diseases, or any history of this type of diseases among their families. So are they also can be provided the genetic counseling before the conception. So that was all about the preconceptional counseling and care. Now moving towards the antenatal care, or we can say what are the treatment modalities that we are supposed to do, conduct and carry during the antenatal period. The main goal of this this diagnostic modalities are that we want to ascertain, we want to see whether the growth and well-being of the fetus and mother is okay or not. Okay, so through this through these diagnostic modalities, we can see whether the growth of the fetus that is occurring properly or not, the development of the fetus that is occurring normally or not, and along with that, the mother's health that is going well or not. So that can be seen. Again, this high-risk pregnancy can be screened. So screening of the high-risk pregnancy and the others maternal and intrauterine factors. Okay, so first of all, we can screen the high-risk pregnancy and any factors which can affect the maternal and intrauterine health, the fetus health. So those can be averted. Okay, like if the woman's HB is less, then we can definitely give her iron folic acid supplementation and all. So thus we can improve her HB status, and definitely through that if improving the HB status will lead to a good maternal outcome during the postnatal period and again to the fetus too. Okay, so that can be done. Detecting early congenital anomalies and some of the inborn metabolic disorders. Okay, so congenital abnormalities that also can be detected, and some inborn metabolic disorders that also can be detected, and if needed. So this congenital abnormalities are very gross congenital abnormalities, and these metabolic disease disorders which may hamper the fetal outcome, or even we can say the abortion services that can be provided if this fetus is having gross anomalies and the pregnancy cannot be continued. So we can counsel the parents regarding it and the abortion services that can be provided. Now, objective of this diagnostic evaluation is that we want first the determination of the gestational age. Now, it is again very, very important that the right gestational age should be determined. Okay, because whatever the development of the fetus that occurs, that we correlate with the gestational age. And so many times it happens that the woman comes to us and she may not be knowing about her last LMP, last menstrual period. She might be unaware of the exact date of the LMP. Okay, so that happens with us. So many women from the rural areas, they come, or sometimes illiterate women, they come and they don't know the exact LMP, and it become a difficult task to determine the gestational age. Okay, so that we want to see. Then they discover the fetal congenital anomalies that we had already seen, like the fetal congenital anomalies. If gross anomalies is there, which type of anomalies is there, and according to that, we can counsel the parents whether they want to continue with the pregnancy or not, or whether they want to terminate the pregnancy. So the options, the counseling can be done. The options can be chosen by the parents. Then detect the abnormalities of fetal growth. If the growth of the fetus that is abnormal, if if it is intrauterine growth retardation or very large baby or any other abnormalities is there, so that also can be detected. And detect and determine the severity of severity of acute and chronic fetal hypoxia. Okay, so fetal hypoxia, again, the fetal hypoxia is one of the very, very major cause of the fetal compromise, or very, very major cause of some of the complications to the babies. So that again we can determine, and sometimes it may be acute fetal hypoxia, and sometimes it may be chronic fetal hypoxia, and that how it will be affecting the child's health, that also can be detected. So that was all about the objectives of this antenatal diagnostic modalities, so that we want to see whether the growth of the fetus is appropriate or not. The gestational week is appropriate according to see the gestational week, and according to that the growth of the fetus is appropriate or not, or maybe the fetus is having any type of congenital abnormalities or fetal hypoxia. So these all can be detected. Now, when we see these diagnostic modalities, we can bifurcate this diagnostic modalities into areas like early pregnancy, the diagnostic modalities which is done during the early pregnancy, and the diagnostic modalities which is done during the late pregnancy. Okay, so in the early pregnancy, again, the three types of modalities are used. One is biophysical, biochemical, and cytogenic. Okay, so we'll see one by one what are these investigations. So biochemical, biophysical, and cytogenic investigations. Now, first of all, we will see the biochemical. Okay. Now, biochemical, the maternal serum alpha fetoprotein, maternal serum alpha fetoprotein, you all must be aware of it. This is one of the very common diagnostic method which is used to determine the or to diagnose the Down syndrome. So, what is it? This alpha fetoprotein is a fetal protein which is normally produced in the yolk sac and the fetal liver. Okay, so now it is found in increasing amount in the maternal serum after the 12 weeks of the pregnancy, and normally it enters the amniotic fluid with the fetal urine. When the fetus passes the urine, through that it enters into the amniotic fluid, and through the amniotic fluid it enters into the maternal circulation. Now normally what happens that this if sorry in cases of neural tube defect, so this normally this maternal the alpha fetoprotein is secreted, but in case of neural tube defect, what happens, this additional alpha fetoprotein that leaks into the amniotic fluid. So additional more amount of alpha fetoprotein is leaked into the amniotic fluid. That means this passes through the placenta and it comes into the circulation in the maternal blood, and that can be screened. So when we do the screening, that is done between the 14 to 20 weeks of pregnancy. Okay, so and through this we can assess different diagnosis. We can make the different diagnosis. Now, in which condition this maternal serum alpha fetoprotein elevates? Okay, if increases, like if underestimated gestational week. Okay. So gestational week is more, but we have underestimated it. So in that condition, if it is multiple pregnancy, definitely the two fetuses are there, so more amount of alpha fetoprotein will be secreted. Then the renal anomalies, then esophageal and duodenal atresia is there, open neural tube defect, anterior abdominal wall defects of the fetus. So fetus is having an type of anterior abdominal wall defects, and the placental chorioangioma. So these are the conditions where the maternal serum alpha fetoprotein level increases. Now, the conditions where the maternal serum alpha fetoprotein level is decreased, which is found low. Okay, so in the chromosomal trisomies, specifically we can see the Down syndrome. So the chromosomal triome is the Down syndrome, in that it lows. Then overestimated gestational age. The gestational age, like if it is 30 and we have estimated it 34, 36. Okay, so it is estimated overly. Then the gestational trophoblastic disease. So GTD is there, and intrauterine fetal death. So in all this condition, the maternal serum alpha fetoprotein is found normally low. Okay, so so this is how we can assess the maternal serum alpha fetoprotein level, and we can make the diagnosis whether it is increased, whether it is decreased. One another thing, sometimes it may happen that there may not be any anomalies present among the baby, but if there is deviation in the normal maternal serum alpha fetoprotein, the chances of the poor fetal outcome that increases. Okay, so there is no anomaly, but the chances of the poor fetal outcome that increases with the abnormal value. Okay. So that is about the that was about the maternal serum alpha fetoprotein. Now, some other biochemical tests that we will see, that human chorionic gonadotrophin (HCG). So as we all are aware that it is a glycoprotein hormone, and specifically it is produced in pregnancy by this sensortrophoblast, and normally what happens, this amount of HCG, that abnormal high level of HCG, that suggests that the abnormal developing fetus is there in the hydatiform mole. If the pregnancy is having the hydatiform mole, so in that condition, abnormal high level of the HCG is found. Okay, and the abnormal slow production in early pregnancy, that is associated with threatened abortion and ectopic pregnancy. Now, what happens that the HCG again responsible to maintain the pregnancy. Okay, so what happens, like if you had already learned about it, you know that the HCG is that inform the corpus luteum to maintain, to secrete, to continue the secretion of estrogen and progesterone again important to maintain the intensity of the endometrium. So thus the pregnancy is continued. Okay, so if slow level or low or level of HCG, that will hamper this whole process, and due to that threaten abortion that can occur, and even the ectopic pregnancies happens. Normally, the SCG plasma level that rise rapidly and double in concentration every 1.5 to 2 days. Every 1.5 to 2 days, this SCG level that doubles in the plasma. So that is the SCG level. Okay, next is the acetylcholine esterase. Okay, now acetylcholine esterase, sorry, it is again a cholinergic enzyme, and which is found in the postsynaptic neuromuscular junctions, which is normally found among the muscles and nerves. Okay, so again, this is elevated in the open neural tube defect. Now, open neural tube defect, the chances are that this enzymes that secretes more through this open neural tube. Okay, and this is having the acetylcholine esterase. This diagnostic value, it is having the better diagnostic value than the maternal serum alpha fetoprotein. Okay, so if we had already seen the maternal serum alpha fetoprotein that is diagnosed for NTD, neural tube defect. So if we compare both the maternal alpha fetoprotein and acetylcholine esterase, the acetylcholine esterase is having the better diagnostic value for the diagnosis of open neural tube defect. Okay. The next is inhibin A. Okay. Now, inhibin A is again a dimeric glycoprotein which is produced by the corpus luteum and the placenta during the pregnancy. Okay. Now, normally this inhibin A is very high level in the second trimester of the pregnancy, and which is normally associated with the abnormal placentation. And if the inhibin A level is increased, which suggests that the risk of preeclampsia is there, the fetal growth retardation could be there, and even the premature labor that can occur. So that's how the inhibin works. Okay, so inhibin A, again the inhibin A in serum level that is increases if the woman carries a Down syndrome baby. Okay, so if the pregnancy is of a Down syndrome baby, then again the inhibin A level that increases in the serum. Okay. So these are the three other biomedical tests, such as SCG, acetylcholine esterase, and inhibin A, to diagnose different diagnosis like of Down syndrome and open neural tube defect and all. Okay. Next are the biomedical test, which is triple test. Now, triple test is a combined test of like biomedical test, whether there the maternal serum alpha fetoprotein and SCG and unconjugated estriol, that is UE3. So these all are tested, and which is used to determine the Down syndrome. Okay, so what happens if the baby is Down syndrome? Then maternal serum alpha fetoprotein and UE3 is low and SCG is high. Okay, so if the pregnancy is affected with the Down syndrome baby, then MSAFP and UE3 is low and SCG is high. Okay. Then another one is pregnancy associated plasma protein A, that is PAP-A. So again, it is used for the first trimester screening of the Down syndrome. Okay. So these all tests mostly done during the second trimester after 12 weeks of pregnancy. So this is PAP-A can be used during the first trimester screening of the Down syndrome. Normally the two markers are used for this PAP-A. So low level of PAP-A and high level of beta SCG. Okay. So PAP-A is low and the beta SCG is high. So which indicates that it is a Down syndrome baby. Next is the Coombs test. So again, it is used for the RH incompatibility. Okay, so the value of the Coombs test is greater than 1:8 and 1:16. Then we can go for the amniocentesis for the diagnosis and for the diagnosis of need for intrauterine transfusion. Okay, so if excuse me. Yeah, excuse me, please. If the participants can mute yourself. Okay. So if the fetus is having
and passing given कई कॉल अच्छा रेसिंग होंगी यार हमारे इसको जज
okay, if the baby is having fetal anemia is there, so we can go for the diagnosis of amniocentesis can be done, and that we can diagnose whether the baby needs intrauterine transfusion or not. Okay. Again, it is used to detect the presence or absence of the maternal antibodies on the fetal red cells, which may lead to the fetal anemia. And if there are no antibodies is found during the first test of arranging Coombs test, then this blood test is retested again on 28th and 34 weeks of the pregnancy to see the RH incompatibility. Now, these are some of the summary of the values, how we can diagnose different conditions based on this evaluation. Okay, this is the three markers: maternal serum alpha fetoprotein, UE3, and HCG. So in neural tube defect, the maternal serum alpha fetoprotein is increased, UE3 is normal, and HCG is normal. And if it is trisomy 21, so in that condition, maternal serum alpha fetoprotein MSAFP and UE3 is low, while HCG is increased. In trisomy 18 condition, AFP and UE3 is low, and again SCG2. So trisomy 18, all the values of AFP, UE3, and SCG are low, and the molar pregnancy is there. So then AFP and UE3 is low, while the SCG is very high. And the multiple pregnancy, alpha fetoprotein that is increased, UE3 is normal, and again SCG is increased. And if the fetal death is there, so at that condition, AFP is increased, while UE3 and SCG is found low. So this is how some of the markers can be identified to make the diagnosis. Now, while we are talking about these all biochemical values, these are not an absolute diagnosis. These are the probable diagnosis, and we can make the risk assessment, okay, through these values, and the further, or we can say the proper diagnosis should be done based on the amniocentesis or chorionuclei sampling or other means of genetic evaluations. Now see the second is that was all about the biochemical diagnostic methods that we use. The second is the cytogenic. Okay. Now the cytogenic, that is pre-implantation genetic diagnosis, PGD, that is done. Okay, so what happens, this is pre-implantation. Normally it is done in the condition of IVF. So both the parents are having the genetic problems, okay, abnormalities, both the parents having the genetic abnormalities. So at that time we do this pre-implantation genetic diagnosis, PGD. It is performed on the embryo, and we want to see whether this embryo is affected or it carries those genetic abnormality or not. If it is not, then only it is implanted into the maternal womb. Okay, so that is done. Or sometimes the peri-implantation genetic screening, PGS, that refers to techniques where the embryos are presumed chromosomally normal genetic parents and screened for the aneuploidy. Okay, so PGD is done. So when we want, when any of the parents is having any genetic abnormalities, and the PGS is done when the parents doesn't have any, they don't have any type of genetic abnormalities, but we want to see whether this embryo which is fertilized, this embryo is carried any aneuploidy or any chromosomal abnormalities is there, so that we want to see. And then only after that, once it is okay, there is no any abnormalities, and then we implant this. Okay, so first we take the biopsy and all, we cellular biopsy, and that we make the genetic assessment, and then once the result is found, and after that we transfer the embryo into the maternal womb. So that is done. The second is fluorescence in situ hybridization, that is FISH, short form is FISH. So this is a diagnostic prenatal test, which again looks for a few common chromosomal anomalies like trisomy 13, that is Patel syndrome, trisomy 18, that is Edwards syndrome, and trisomy 21, Down syndrome. So these are the different trisomies that we see, we diagnose through this fish. Okay, so now this fish does not have any false positive results. So if the fetal cells contain certain chromosomal abnormalities, this will be apparent with the fish test. Okay, so it doesn't give any false positive results. So if definitely the fetus cell is having these chromosomal abnormalities, then it is shown through this test. It is identified through this test. Okay, so only exception can occur, but in this condition, whether the parent has a chromosomal abnormality and the fetal cells are contaminated with parental cells. Okay, sometimes it may happen that the fetus might not be contaminated, might not be having these chromosomal abnormalities, but the parent might be having these chromosomal abnormalities and their cells. So, okay, so the fetal cells are contaminated with those parent cells, and in that condition, the false positive can occur, but it is a very, very rare exception thing happens. Then next is the DNA amplification, using the polymerase chain reactions. Okay, so this is again a DNA analysis is done. So it provides the convenient and efficient means of making millions of copies of short DNA sequences. So DNA like this again, okay, through the various chorionic villus sampling or through the amniocentesis, okay, or chordosynthesis, we get the samples of the fetus, and from that we extract the DNA, okay, and that DNA is analyzed. Now through this DNA amplification, what happens, this is like a hot and cold method type of things where from the whatever the little amount of specimen that we get, from those specimen we can amplify, we can make millions copies of DNA, we can make millions copies of DNA sequences, and through that
જો એક તો ડીપ જન વેલ્યુ ચેન્જીસ ઉંમરના લીધે થાય અને રક્ત મસલ્સ જે ટેન્ડન છે ને એકદમ ચેન્જીસ ના લીધે ફેક સર્ટિફિકેટ કોણ આપે
excuse me
કોઈ બી આલા એ જઈને
again
આપણા ડોક્ટરને કહી દો યાર એમાં હું છે ના હું કરી આલા મોનિકા મેડમને કહી દો અનફિટ નું લખી આલો કે અઠવાડિયા માટે ના ના પેલા ધ્રુવ સરનું લઈ લો આપણે ગાયનેક છે
okay. Would like to request all the participants if they can mute themselves. Okay, thank you so much. So what happens, like this is cycle 1, first we get samples, and from that, like numerical, through the different cycles we get more and more DNA sequences. Okay, so this can be used for assessing the genetic variation and for diagnosing the different genetic diseases, and even for the forensic purpose too. Okay, like if the rape, assault or something type happened, and due to that the pregnancy, or we want to see the paternity test of the baby, so in that cases too we can assess it, and can be directly obtained from the fetus the samples. So that was the DNA amplification, which is used with the use of the PCR. Then amniocentesis. Now amniocentesis is one of the, we can say, very, very old method or old diagnostic evaluation and diagnostic method which is done to diagnose various genetic and chromosomal abnormalities among the fetus baby. Okay, so again it is an invasive procedure. So it is traditionally performed between 14 to 18 weeks of the gestational, but nowadays it is again performed between 12 to 14 days. So it is performed earliest, so during the end of the first trimester itself it can be performed, so that we can get the early diagnosis of the fetus condition, and the further treatment modalities, or we can say the further options, can be provided to the parents regarding continuation of the pregnancy or not. Okay, so now amniocentesis can be used in a two-way, like for the diagnostic purposes also and for the therapeutic use also. Okay, Now for the diagnostic use, what we do, the genetic testing can be done, the fetal lung testing that can be done, fetal infection that can be assessed. If the baby is like RH sensitization, in that case is a severity of anemia among the babies that can be assessed, and through that we can see whether we want to go for the fetal transfusion or not. Okay, so intrauterine transfusion or not, that also can be done. And therapeutic use in cases of like polyhydramnias, the excess amount of liquor that can be withdrawn, so that will be helpful to the mother. Okay, so this is a diagnostic. We can see like it is guided under the guidance of the sonography probe. So through the sonography probe that we insert a fine needle into the maternal womb, and we collect the amniotic fluid from the maternal womb. Okay, so this amniotic fluid that contains the like skin debris of the fetus, and that from there we get the DNA and we get the we can do the karyotype and all from that. So it is done under the guidance of sonography, so there won't be any harm and injury to the fetus and other complications that can be at most prevented. Now with this amniocentesis, again, so many risks are associated with the amniocentesis. Okay, so risk is that the maternal infection can occur, and sometimes the hemorrhage can occur, premature rupture of the membrane that may happen, premature, and that may lead to the premature labor, or even in the RH incompatibility isoimmunization that can occur to the women. And the fetus, again, the chances of abortion increases, the trauma to the fetus that also can happen. Again, the fetal maternal hemorrhage, that too can happen. Oligohydramnias, if excess amount of the fluid is drawn, that may lead to the oligohydramnias. Respiratory distress to the fetus, the baby, and fetal lung hypoplasia, that also can happen. So these are the complications that can occur due to the amniocentesis. So it is not done very routinely unless and until we have the biochemical values, markers, and it suggests that there is a risk and the baby is having this type of disorders, or the history of any genetic disorders or chromosomal anomalies among the parents, family, and in the previous obstetric history, then it is normally done. Okay. Now another one is chorionic villi sampling. Again, it is performed for the genetic disorder diagnosis. Okay, so this chorionic villi sampling can be done by two methods: transcervically and transabdominally. So if it is to be done transcervically, it is done between the 10 to 12 week of gestation, and transabdominally, it is done from the 10th week of the gestation. Okay, so that is done. Now, whatever like again, it is done under the guidance of sonography, and with the final needle aspiration, we collect the chorionic villi. Okay, from the placenta, the chorionic villi, this is the chorionic villi that is collected, and that is sent for the genetic disorder diagnosis. Now, whatever the specimen that we obtains from that specimen, the earliest diagnosis can be done. So the diagnosis can be obtained by 24 hours. So if the termination is required, or any other, whatever the counseling that to be done to the women, that can be offered, and the termination, if it is required, that can be done during the first trimester itself. Okay, so we know that the termination, if it is done first trimester, the risk to the women that is decreases. But if as the pregnancy progresses, and if it to be done the termination during the second trimester and all, so the risk factor increases. So that also can be saved. The technique that is used in CVS are direct vision, so with the hysteroscope and sonography that we use, and through the transabdominal or transvaginal sonography, and through that we collect the specimen. Sorry. Then fetoscopy. So fetoscopy is again an ultrasound scan that is performed immediately prior to the technique, so that the damage to the placenta and fetus is kept to the minimum. Okay. So fetoscopy, like if we want to perform any chorionuclei sampling, or we want to perform amniocentesis or any type of invasive procedures, at that time also we can perform the fetoscopy, so that the place, where is the place of the placenta, the fetus condition, the position of the fetus, these all can be ascertained, and according to that we can do the further procedures. Okay. It can be performed in 18 to 20 weeks of the during the 18 to 20 weeks, and during this fetoscopy, through the fetoscopy, we can assess, we can take the fetal liver biopsy to diagnose the fetal metabolic disorders that can be diagnosed. Fetal skin biopsy can be obtained to see whether the baby is having any type of skin disorders. Not only that, but this fetoscopy that can again used to do the corrective surgeries during the fetal period only, intrauterine period, the fetal corrective surgeries and some procedures that also can be done. Okay, so this is how the fetoscopy, through the fetoscopy, they are doing one endoscope, okay, of the fetus during the in the intrauterine period only. So various treatment or corrective surgeries can be done during through this fetoscope. Now, this is percutaneous umbilical cord blood sampling, chordosynthesis, that also we see. Okay. Now, now what happens through this? Directly, we can access the fetal circulation during the second and third trimester, and through this chordosynthesis, we can directly collect the fetal blood. Okay. So it is a widely used method for the fetal blood sampling and the transfusion. Not only fetal blood sampling, but if we want to transfuse the blood in the fetal anemia, gross fetal anemia condition, severe fetal anemia condition. So in that condition, in that case, we can transfuse the blood through this method too. Okay, it is now the route of choice for intrauterine transfusion for severely anemic fetuses, and at earliest, like during the 19 weeks of the pregnancy, we can start this transfusion too. Normally, this anemic condition that occurs into the RH incompatibility, okay, RH isoimmunization condition. So at that time, we may need to give the transfusion to the baby. And this is again done under the ultrasound probe guidance, so that any complication to the fetus and the mother that can be avoided and prevented. So that was all about some of the cytogenic assessment that is done to assess the genetic disorders or chromosomal anomalies, to make some or to collect the samples from the fetus and the maternal womb, so that this analysis that can be done. Okay. The next is biophysical, some of the biophysical investigation that is done. Now, ultrasonography, USG, we all are aware of this ultrasonography it is done. Okay, so it is done examination of the fetus in the early weeks, 10 to 14 weeks. Okay, now sonography can be done transabdominally and transvaginally too. So in the first in the first trimester, or during the 4th, 5th week of gestation too, we can go for the transvaginal sonography, and we can see whether the conception occurred or not. Okay, so after 10 to 14 week of pregnancy, during that period, we do the ultrasonography to detect if the fetus is having any anomalies, okay, any structural anomalies, okay, physical anomalies that can be assessed through the sonography. Through the sonography, this detection rate is about 70 to 80%, and the false positive chances rate is 5 to 6%. Okay, so as we had seen that it can be done transvaginal and abdominal. Furtherly, the sonography can be done to see the gestational week of pregnancy. Like sometimes it may happen the women may not be aware of the LMP, and so with the growth of the fetus, we can see with what could be the gestational week. Again, the sonography not only for the detection of anomalies, but again, we can see the growth and development of the fetus, if it is normally occurring or not, the liquor of the amniotic fluid, the level of amniotic fluid is proper or not, according to the gestational week, it is appropriate or not. So that can be done. Okay, the position of the fetus. So these all can be assessed through the ultrasonography. Then one other modalities is that cardio tomography. Now, what is cardiotomography? It is a very high definition of ultrasonographic procedure. So through this procedure, we can evaluate the fetal cardiac structural or functional anomalies, parameters that can be assessed. Okay, so fetal cardiac structural and functional parameters that can be assessed through this cardiotomography. And if sometimes what happens, the mother is having some type of disorders, like specifically diabetes mellitus or hypertensive disorders, and how these disorders of the mother can affect the baby's health. So that also can be assessed through this cardiotomography. Now, next is MRI. So we all are aware of the MRI. Now, sonography, in the mostly sonographies, we can see the outer structural abnormalities of the babies. But through the through the MRI, the soft tissue abnormalities. Okay, so USG will not be able to detect, that won't be detecting the soft tissue abnormalities, but MRI can detect the tissue abnormalities. So it is a non-invasive procedure, and again it can be used for the fetal well-being assessment. So the MRI radiology technique that is used, and we can see the baby, okay, the fetus which lies in the maternal womb, that can be seen the different gestational weeks, and according to the fetus condition that can be stated. Okay, so the each and every part, like the body's tissues, the fetus tissues and cells and everything, the body structure, that can be imagined, that can be assessed through the MRI. Okay. So the fetus condition, the placental condition, the uterus conditions. Okay, so these all can be assessed through the MRI. So whatever the soft tissue assessment cannot be done by the USG, that those abnormalities are assessed through the MRI. Okay. So that was all about the early pregnancy. So in the early pregnancy, what are the biochemical, what are the cytogenic, and what are the biophysical assessment that we do? Okay. So hello, am I audible?
Yes, ma'am.
Yeah. Thank you so much. So now moving towards the late pregnancy. So late pregnancy, what are the diagnostic methods that are used? Like that also divided into three: clinical, biochemical, and biophysical. Normally, during the early pregnancy, we want to see whether the baby is having any abnormalities, anomalies, okay, is having any type of genetic disorders or chromosomal abnormalities. These all can be assessed during the early pregnancy. And the late pregnancy is more concerned with the health of the mother as well as the fetus. The fetus is growing properly or not, or what is the condition of the fetus, that is assessed. Now, the clinical evaluation that can be done by different methods. That is, first is the maternal weight gain. We all know we assess the weight and we compare whether the normal average weight gain is occurring or not. Average 11 to 12 kg of weight gain occurs throughout the pregnancy. Again, during the first, second, and third trimester, different type of weight gain occurs. During the second half of the pregnancy, normally the weight gain is like 1 kg per fortnight. So that is. So if there is excess weight gain, that is could be a first sign of preeclampsia. Now we know that the preeclampsia is one of the major complication of among the women, and that is again one of the major factor of the maternal morbidities and mortalities. So that also can be assessed. And then if the weight gain is less than the normal, or it is like falling. Okay, it is stationary, it is not increasing, not decreasing, or either it is decreasing. So in that condition, IUGR condition, intrauterine growth retardation, could be the possible causes. So that is there. Then the blood pressure is assessed. Now we know that during recording of BP prior to 12 weeks. So before 12 weeks of gestational period, when we so before 12 weeks of gestation, if when we assess the blood pressure, so we will be able to differentiate the pre-existing chronic hypertension from the pregnancy-induced hypertension. Normally, PAH occurs during the second trimester. So, okay. So, if the woman is already chronic hypertensive or not, that can be diagnosed, and the hypertension or like during each antenatal visits, we should measure the blood pressure, whether the woman is chronic hypertensive or she is having a pregnancy induced hypertension or whatever, but the chances of impaired fetal growth is high in the high blood pressure. So it is very, very important that throughout the pregnancy, the proper monitoring of the blood pressure should be done. Then the fetal fundal height and abdominal girth. Again, the fundal height and abdominal girth that is measured to determine the size of the uterus. And as the pregnancy progresses, we all know that the fundal height increases, and we with whatever the fundal height that we get, we correlate it with the gestational age or gestational week of the pregnancy, so that we can come to know whether the pregnancy is the growth of the baby is occurring normally or not. Okay, so that can be done. And after 24 weeks of pregnancy, normally the distance which is measured in centimeter from the symphysis pubis to the fundus, it corresponds to the gestational period of gestation. Okay, if it is like 26 week of gestation, the chances the fundal height is normally of 26 centimeter. Okay, so that is done. And abdominal girth, specifically in cases of multiple pregnancy, gestational hypertension, hypertensive disorders among the of the women. So in that condition, to assess generalized edema and all, we see the abdominal girth. Okay. Then the clinical assessment of the liquor, amniotic fluid. So amniotic fluid, that approximate volume of the amniotic fluid, like at 18 weeks of pregnancy, it is nearby 500 ml. At 34 weeks of pregnancy, it is nearby 800 ml. And at term, it is nearby 600 ml. Okay, so these are the on an average approximate volume of the presence of amniotic liquor. Now, the clinical assessment of the amniotic fluid is not very reliable, and we have to rely on the USG. Objective assessment that can be done through the USG. While we do the sonography, we see the amniotic pool of the amniotic fluid, and from that, the amniotic fluid index that can be measured. So these were the 4 markers of the clinical assessment that we do. Okay. Sorry. The next is biochemical. Now, biochemical assessment, that shake test or the bubble test, that is done. Now, this test is done to see the pulmonary maturity of the fetus. Okay. So what happens? The pulmonary surfactant, it is having an ability to form a bubble. Okay, in the presence of ethanol, when this pulmonary surfactant, it comes into contact with the ethanol, it forms the bubble. Pardon? Okay. So this whatever the amniotic fluid that we have, this amniotic fluid that we take, and it is mixed with the 96% of ethanol, and this well or this test tube that is bottle is shaken for 15 seconds and inspected for after 15 minutes. Okay, so what we do, we mix the amniotic fluid with the ethanol, we shake it for 15 seconds, we keep it for 15 minutes, and after 15 minutes we see whether there is a presence of complete ring of bubbles at the meniscus, and normally it is due to the presence of the amniotic fluid lecithin, which suggests the pulmonary maturity. Okay, so this is the positive. The ring can be seen, like a ring can be seen, the bubble can be seen. Okay, negative, no any bubble. Okay, so if the bubble and ring is present, that indicates that the fetal lung maturity is there. So that is shake test or bubble test that we say. The next is foam stability index FSI test. So again, it is a variation of shake test, same like little bit of like a shake test only. So some this FSI kit is available. So each contains this which contains ethanol. So different well. So we will see this boxes as a well. Okay, so different boxes of this well of containers are there which contains ethanol. The fixed amount of ethanol is present is there in all these boxes, and then 0.5 ml of amniotic fluid is added in this wells. Okay, so different wells or whatever the well that we are having, so that is there. So what we take 0.5 ml of amniotic fluid, we mix in the ethanol container, and then we shake it, this mixture that's shaken very well, and after that we measure the level of foam. Okay, now this is like 0 minute. Once we shake it, the foam is very high. Okay, then how after 240 minutes, and okay, so that after 24 hours, so it is completely. So that's how we. So it is again, we want to see the surfactant present, whether in this amniotic fluid, how much amount of surfactant was present, which will indicate the lung maturity and all. Okay, so if the foam stability index level is more than 47, so it excludes the risk of respiratory distress syndrome. Okay, so if the FSI value is more than 47, so which indicates that if the baby will be born, so that baby, the likelihood chance of getting respiratory distress syndrome is very, very less. Now, other different tests also done for the fetal lung maturity, that is presence of phosphatidyl glycerol, PG, saturated phosphatidyl choline, and amniotic fluid optical density, fluorescence pluralizations marker. So these all other tests are again done to assess the fetal lung maturity. Okay, normally these all tests are done in cases of premature rupture of the membrane and the preterm labor, so that we want to see how much lung maturity occurs, and if the baby is delivered, what could be the condition of the fetus that can be anticipated. Okay. So that was the biochemical assessment. Now moving forward, the biophysical assessment during the late pregnancy. Now what are those? Okay, fetal movement count, being midwifery students or midwifery educators, we all are aware of this, one of the very simple method which is used to see the fetal well-being. Okay, to assess the fetal well-being. So it is cardiac done. The fetal movement count can be assessed through two methods: cardiac count 10, so where the mother counts fetal movement starting from 9 a.m. to and the counting ends when 10 movements are perceived. Okay, so morning in the 9 a.m. she's supposed to start her counting, and then whenever she will have 10 movements, so the counting ends, and so during how much duration it took for this 10 movements, that is notified. Okay, so if the movements less than 10 movements occur during 12 hours on successive 2 days, then we have to report it to the physician. Okay, so less than 10 movements in 12 hours for successive 2 days, and then there is no movement in even for 12 hours in a single day. Okay, single day, not a single movement, then again it should be notified. Then second is the daily fetal movement count, that is DFMC. So during morning, evening, afternoon and evening, 1 hour duration each. In morning, afternoon and evening, 1 hour duration, they have to count how many fetal movement the mother felt. Okay, so whatever number of fetal movement that the women felt, that should be multiplied by 4, and that's how we see how many total counts were there. Okay, so if there is a diminution of number of kicks into less than 10 in 12 hours or less than 3 in each hour, so it is again indicates the fetal compromise. Okay, so both condition that like fetal movement when the fetal compromise occurs, the chronic fetal hypoxia. Okay, so these all conditions will lead to the decreased fetal movement. So that's why we want to count the fetal movement is okay or not. If the fetal movement is okay, so it suggests that the fetus is okay. Okay, so that can be determined. The next is non-stress test, NST. A very common test again that is performed. So here what we do, like you can see, this is an NST machine where the one probe that, okay. So this monitor that is kept over the belly of the woman to assess the fetal heart rate, and one probe is being given to the woman. So whenever she felt the movement, the fetal movement, she can press that probe, and thus the whole, this is the whole graph of the fetal NST that is assessed. Okay. So it is a test which monitors the fetal heart rate in response to the fetal movements, okay, to assess the integrity of fetal central nervous system and cardiovascular system. So normally what happens whenever the fetal movement occurs, there should be acceleration of the fetal heart rate, and there will be movement, and then the heart rate will increase. The non-stress test, sorry, the NST, which involves the application of the fetal monitor, which records the fetal heart rate, and the marker, push marker, that button that is given to the mother, which is she instruct to push. So whenever the fetal movement is there, and we can see whether the sufficient placental functioning is there, or during the movement, the fetal heart rate, which is accelerated or not, that can be seen. Okay, so this is how we can interpret the results, like reactive non-stress test, normal. Okay. So reactive, it suggests that is normal. Okay, so reactive indicates a healthy fetus. So whenever this, like here, there is a fetal movement and the acceleration of the cardiac fetal heart rate. Okay, here a fetal movement and the acceleration of the cardiac fetal heart rate. Okay, so this is the reactive non-stress test. So presence of 2 or more FHR acceleration during 20 minutes. 20 minutes of time, 2 or more FHR acceleration, with each acceleration of 15 beats or more per minute and lasting 15 or more seconds. Okay, so ड्यूरिंग 20 मिनट्स 20 मिनट में हर 20 मिनट के अंदर 2 से ज्यादा एफएचआर एक्सेलरेशन होना चाहिए, एंड दिस एक्सेलरेशन शुड बी ऑफ नॉर्मल से जो चल रहा है, जो वट एवर द फीटल हार्ट रेट है उससे 15 एटलीस्ट मिनिमम 15 बीट्स ज्यादा होना चाहिए. If suppose it would have been before the moment the baby had 130 and after the moment at least the baby should have 145 fetal heart rate. Okay, so that should be there, and this acceleration that should last for 15 or more seconds. Okay, so that is how that can be assessed through this strip, and that is reactive non-stress. It's a normal. And abnormal, absence of acceleration. There is no any acceleration, and normally it is associated with the chronic hypoxia. Okay, ek hi usme ja raha hai na, everything it goes on a very steady. Now it is a steady, it is again not good. If during the fetal movement, if it is not accelerated, again it shows that chances are the fetal hypoxia is there. Okay, so that is the NST. Now second is vibroacoustic fetal acoustic stimulation test, or vibroacoustic stimulation test, or fetal acoustic stimulation test. Now what it is? So it is like a fetus is started with a loud sound with the use of artificial larynxes or electric toothbrush. Okay, so fetus, it is one type of NST only, but it is more easier than the NST. Now like stimulator is there, so that stimulator could be an artificial larynxes or electric toothbrush. So with this sound the fetus is started, so it arouses the baby from the sleep cycle, and again it's also shorten the time taken for the NST. Okay, so what we do, this stimulator that is held briefly for 1 to 2 seconds on the maternal abdomen near the fetal head. fetal head, when we do the abdominal palpation, और उसके बाद हमको पता चलता है कि कहाँ पे fetal head है. According to that, fetal head के ऊपर जहाँ पे भी है abdomen पे, maternal abdomen पे, so we put the stimulator for 1 to 2 seconds only, and through that we arouse the baby from the sleep cycle. Okay. So we do. So if the response is not seen up to 3 repeat stimulus, then it gives given for longer periods. 1 to 2 seconds of stimulation and 3 बार देते हैं after 10 to 15 minutes के interval में, and after that also after 3 repeat stimulus there is no any response from the baby, then we give it for a longer period, that is more 3 seconds or 3 to 4 seconds that we give the stimulation. Okay, and then again we see the evaluation. If after that also there is an absence of response, which indicates that the fetus might be compromised. Okay, there is no any movement after this stimulation also, there is no any movement which suggests that fetus is compromised. Okay. Now another is auscultated acceleration test or auscultated NST, that also we say. Now it is performed by this is one type of NST which is performed by auscultation with the fetoscope. Okay. Now what we do, it is used to detect the fetal heart acceleration by a specific counting method with the use of Doppler fetoscope. Okay. So with the fetoscope, we count the fetal heart rate. So it is conducted by the 2 clinicians, and one clinician, they auscultate and report the fetal heart rate, and the other records the findings. Okay. So this is NST. So where this facility is not there, the NST facility is not there in the peripheral, and that in those areas we can go for this auscultated NST. So auscultated NST, that through the Doppler fetoscope, when the fetal movement occurs, at that time we assess the fetal heart rate and we note that the fetal acceleration is there or not. Okay, so 2 persons will record this, will go for this procedure. One will be recording and the auscultation, and another will be recording the findings. Okay. So when 2 accelerations are noted in a 20-minute FHR recording, then the chance of stillbirth within the next 7 days is less than 1%. Okay. So within 20 minutes, 2 acceleration of fetal heart rate is noted. So it suggests that for the next 7 days, the chances of stillbirth is less than 1%. Okay. So here, where the resources are less in the peripheral and all, so this method can be used. Then the contraction stress test. Again, it is a test performed during the pregnancy to verify whether the unborn baby's heart is strong enough to withstand the labor. So the artificially the contractions are stimulated through the nipple stimulation or with the use of drugs. Okay, and when these contractions are stimulated, and after that we see the fetal heart rate during the contraction, how the fetal heart rate is whether it is accelerated, whether it is decelerated, how much amount, or we can say what is the evaluation. Okay, how much number of the heart rate is increased or decreased. These all things that is seen, and we can see through this, we can see whether the fetus will be able to sustain the contractions or not. Normally, this CST test is done when we have some other abnormal results during the other pregnancy health examination, and then we go for this CST. So if it reveals that the baby has an abnormal heart rate during the contraction, or sometimes it may happen slowing heartbeats during the or immediately following the contraction, and it will indicate the fetal distress. So based on that, we can take a decision whether we would like to induce the labor or not, or if it is the baby is compromised during the contraction, we should not go for it. Okay. Then next is the fetal cardiotocography. Again, it is a recording of the fetal heartbeat and the uterine contraction during the pregnancy. Okay, during the 3rd trimester. So there are 2 measurements can done, external measurement. So externally the probe. Okay. So for the uterine contraction and for the heartbeat, fetal heartbeat. So 2 probes are put over the abdomen to see the uterine contraction and for the fetal heart rate. Okay. So intrauterine pressure and fetal heart rate and everything that can be monitored. And this is the second is the internal measurement. So because we want to introduce a catheter into the cervix, so a little bit of cervical dilatation is necessary for this. So a pressure catheter that is inserted through the cervix into the uterine cavity, and that is attached into the scalp. Okay, scalp electrode that is attached over the fetus scalp, and to see the electrical activity of the fetal heart. So that can be done. So fetal cardiotocography, both the external and internal measurements can be done. So during the contraction, how the fetus. Now this is the biophysical physical profile, fetal movement, fetal tone, FHR, amniotic fluid volume, and fetal breathing that can be assessed. So this is how the results can be verified. There is score 2 and score 0, FHR. If the baby's heartbeat accelerates twice or more within 20 minutes, score 2, and it is not appropriate the marks, then score 0. Breathing movement, at least one episode of rhythmic breathing for 30 seconds or more within 30 minutes, then score 2, and there is no rhythmic breathing, 0. Body movement, 3 or more times baby moves his or her limbs within 30 minutes, then 2 score, and less than 3 or no movement, then 0. Fetal tone, at least one episode of limb flexion and sudden extension and rapid extension. So that is for, so score 2, and no limb movement or very slow flexion, slow extension. Okay, so that is 0. Amniotic fluid volume, the more than one pocket of one pocket of amniotic fluid which contains more than 1 centimeter of depth in 2 perpendicular plane. So that is 2. So that is amniotic fluid volume. That these all breathing movement, fetal body movement, fetal tone, and amniotic fluid movement, these all are assessed through the sonography. So that is score 2, and if largest pocket is less than of 1 centimeter, then the score 0. Now, how we can interpret this score? If it is 10, that means we can go for the conservative management, and after 1 week or after 3 days, we can repeat for after 1 week in the normal baby. And if the baby is having IUGR or mother is having diabetes or post maturity, in that after 3 days, again we can go for this assessment. If the reading is the value is 8, so it suggests that liquor is, we have to see whether liquor range is normal or not. Okay, so if the liquor amount is normal, then manage. And if it is less, so post maturity. Liquor amount is less and the post maturity is then we have to immediately deliver. If liquor amount is normal, then manage properly. If the value is 6, then the test should be repeated after 24 hours. And if the value remains same, then we should immediately deliver the baby. And if the value is 4 or less, then it suggests an abnormal condition. So immediate delivery should be conducted, except if the fetus is very grossly immature, then only we should not deliver. We can wait for the other clinical assessment. And if the value is 2 or less than 2, then immediately, irrespective of the gestational week, we have to immediately. Okay, so that. Then another is fetal monitoring with the fetal scalp blood sampling. So fetal scalp blood sampling, that is again done through the cardiotocography, and we want to see the fetal blood scalp pH. So if the research, I think, so abnormal pH which is less than 7.20, so it is in the cases of fetal asphyxia. So we have to immediately deliver the baby. The Doppler sonography is again done to see the sound waves, to detect the movements of the blood in the vessels of the fetus. So the uterine artery, umbilical artery, internal carotid artery, cerebral vessels, all these can be done. Okay, can be seen. So the blood, how it is flowing in the fetus, that can be assessed. These are the These are the other tests which is done to see the assessment of severity of RH isoimmunization. So this is amniotic fluid is assessed by spectrophometric analysis, and we want to see whether the baby is having how much RHIS immunization and fetal anemia. And the amniotic fluid leakage, for that the fun test can be done. Okay, the nitrogen test, whether what is the pH of the vaginal fluid, and according to that amniotic fluid is present or not, that can be assessed. And the EP test, so again the EP test is whether the fetal blood or the maternal blood is present in the vaginal fluid, that can be assessed through the EP test. So these are the various other tests that is performed for the assessment of the fetal well-being. Okay. So that was all about for today's session. Thank you for the patient listening. I know the topic was a little bit lengthy, so it took a little bit of time. Once again, I would like to thank Dinsha Patel College of Nursing for providing me this opportunity to connect and to connect with so many nursing personnel, nursing students and nursing personnel state and country. Thank you so much.
Thank you so much, madam. It was very informative. And you have taken all the tests in very detail, like DNA amplification, amniocentesis, chorion-Williams sampling technique, and it was very nice. And now this is the time for the discussion. If anyone want to ask any question or want to give any feedback, then they are most welcome. They can unmute themselves. Anyone from group? Okay, now this is the time for the second session. So thank you so much, madam. It was very informative and very nice PPT slides. And now I request Neha, madam.
Thank you.
Yes.
Thank you so much, and it's a pleasure to be with you all. Thank you so much.
Thank you, madam. So within few minutes, we will start the second session.
Very good morning, respected dignitaries and delegates from all the states. I also welcome our today's resource person, Mr. Himanshu Vyas. Sir, are you there? Hello, sir.
Yes, I'm.
Yes. Moving towards another scientific session that truly based on how to deal with the pain during childbirth. Giving birth can add and should be beautiful experience, but the prospect of delivery may give some woman anxiety because of the anticipated pain and discomfort. Pain during labor is different for every woman. It varies widely from woman to woman and even from pregnancy to pregnancy. Woman experiences labor pain differently. For some, it resembles menstrual cramps, and for others, severe pressure. Laboring mothers and moreover nurses must be educated about the different available methods of labor analgesia. Many pharmacological and non-pharmacological methods of labor analgesia have been adopted over the years. To enhance our knowledge in this topic, we are glad to have an eminent personality in nursing profession who may be the role model for many nursing personnel, that is Mr. Himanshu Vyasa. Before Sir comment his expert talk, we will have some glimpse of his career in nursing profession. Sir has completed his BSc Nursing in 2006 and MSc Nursing in OBG specialty in 2010 from Rajiv Gandhi University, Bangalore. And he is presently pursuing PhD from National Consortium Indian Nursing Council, New Delhi. He is presently working as an associate professor and nursing superintendent at AIIMS, Jodhpur. He has 13 years of huge teaching experience and a member of many professional bodies, including Society of Midwives of India. He has published 18 research papers till date. He is also an examiner for UG and PG nursing courses in institutes of national importance. Sir is very confident, hardworking, peaceful, and excellent in communication skill. Sir has a great skill for time management and work priority. We feel very glad and delighted with your presence, sir. Now I request sir for the expert talk. Please, sir. Sir, now you are a host, so you can share your.
Mute જ છે મારું, but your speaker is not working.
Thank you very much. Just want to confirm whether the screen is shared and the slide is visible. Is the slide visible?
ના નહીં સંભળાય. મારા સ્પીકર માં લોતો
Sir, do the slide show.
સંભળાતું મારું નહીં જતું.
I have done the slideshow.
એક મિનિટ પણ કંઈક કરો ને અહીંયાથી.
It's visible to me.
નહીં થઈ રહ્યું. કહું તો છું મેં સાઉન્ડ ફૂલ કર્યો. જો, your speaker is not working. Please check your connection with the different speaker.
Is it visible now?
Yes, sir.
Okay.
Sir, slideshow is not there. You do it again.
Now is it visible?
Yes, sir.
Sir, please share the slideshow because it's not unshare and share.
Now is it okay?
No, sir.
Slideshow I started presentation mode. Please confirm at my place it is in the presentation mode only.
From your side it is okay, but sir, from our side it is not in a slideshow manner.
Okay, let me just give me a second. Now is it?
Sir, please unshare the first and then again sharing the slideshow. First unshare and then slideshow share. Sir, your PPT slide is sharing, but please show the slideshow. Share it again, the slideshow.
I have put it in the presentation mode. Other participants, please confirm, is it visible in the presentation mode?
Sir, yes, it is visible.
Now may I start?
Yes, sir.
Okay, thank you very much. So first of all, again to introduce myself Himanshu Vyas. I am working as associate professor at College of Nursing AIMS Jodhpur since 2013. Basically, I am a resident of Rajasthan only, and I have done my graduation from Rajasthan and post graduation from Rajiv Gandhi University of Health Sciences, and presently pursuing PhD from the National Consortium. I would like to express my heartiest gratitude to Principal Mr. Virendra Jain, who is a friend of mine, and the organizers, organizing secretary, Madam Neha, for giving me this opportunity to address this August gathering. It was very heartening to see the inaugural part of the ceremony. Being an e-conference also, the students were sitting in front and the lamp lighting and the prayers were recited. So it was really heartening to know. And I would like to express my appreciation for Madam Amy Menon for such an elaborative and detailed presentation. It was very much informative. Okay, so the topic for my talk today is labor analgesia and recent advances. I am starting my topic with a brief introduction to what is labor. So as we all know, labor is at times used as a negative term. So nowadays it is started to be replaced by the term birthing process. So better we appreciate it to call as a birthing process. So birthing process is a series of events that take place in the genital organs in an attempt to expel the viable products of conception by the mother's womb through the birth canal. So that is labor. If we talk about the stages of labor, there are mainly 4 stages: the first stage, second stage, third stage, and the fourth stage. That fourth stage is the stage of observation. Then if you talk about the events in the stages, the first stage starts with the onset of the true labor pains and completes with the full dilatation and effacement of the cervix, that is the 10 centimeter. Mother experiences labor pains during this stage, and the duration of this stage is around 12 hours in the primaries and around 6 hours in the multis. Then the second stage of labor starts with the full dilatation of cervix, that is the 10 centimeter, and ends with the delivery of the baby. Around 2 hours in the primary and around 30 minutes in a multi. Then again, the third stage of labor, that is mainly with the delivery of the placenta and membranes for around 15 minutes. And after that, the fourth stage of labor, that is for around 1 to 2 hours for observation. So as we see, the duration of labor is, you can say, almost reduced to half in a multi, and it is more prolonged in a primary. And the experience of the mother, the fear of childbirth is also more in the primary. So management of pain becomes a very important aspect in the primary mothers, especially because of the increased fear and increased duration of labor in the primary. Now, one very important part is labor is a physiological process. Now, as a midwife, all the new midwives, students are listening, all others are listening. You are not audible.
Excuse me, sir.
Yes.
Sir, slides are not moving.
Okay.
Now it is moving, yes, sir.
Now it's fine.
Now it is okay. Yeah.
Okay. So, first of all, every midwife should understand that labor is a physiological process, and before making the women in labor understand that labor is a physiological process, each one of us must have a strong belief that labor is a physiological process, and right from the beginning, from the preconception period, pregnancy, labor, postpartum, everything is a physiological process. And as midwives, what we are doing is we are supporting the women in labor. So before the midwives makes the female or the mother understand it is a physiological process, all the midwives must have a strong belief that our body is prepared to conceive, carry and deliver the healthy baby and take care of the baby's needs by breastfeeding for the first 6 months. Now, if the labor is physiological, then why there is a need for managing labor pain? Now, that is a very long debate that is run from 1940s, 1930s, when the initiation of anesthesia in the form of ether was introduced. That time also debates were there. When it is physiological, then why the pain has to be managed? So, as rightly said by Madam Neha, that as midwives, or as obstetricians or as healthcare personals, our duty is to make the mother aware about what are the options available for pain management and let the mother decide whether she wants to manage the pain of labor by analgesia or how she wants to do. Now, onset of labor pains, as we all know, that one of the very important characteristic of normal labor or euthanasia is it is the spontaneous onset of labor pains. So, if we talk about onset of labor pains, so how it happens, how it starts. So, when the onset is spontaneous, it is at term, obviously, after 37 completed weeks, and there are multiple factors which are responsible for the onset of labor pains, in which a few are like uterine factors, in which because of the increased stretching effect of the growing fetus and the amniotic fluid. Then second is the fetoplacental contribution, in which because of the increased fetal cortisol levels, increased level of estrogen takes place and increased level of prostaglandin takes place. Increased level of estrogen stimulates the secretion of estrogen, oxytocin, as well as increased number of oxytocin receptors in the fundus. As we all know, oxytocin is managed by the positive feedback mechanism. So as labor pain increases, more and more is secreted. Then prostaglandins also a humble request to please mute your mics, Nisha A. Parmar. Then estrogen, after estrogen, prostaglandins, and the change in the estrogen progesterone ratio is also an important factor in commencement of the labor pains. So that was a brief introduction about the process of labor, what are the stages, and how the labor pain starts. Now, if we move on to understanding the labor pains, please confirm the slides are changing. Madam Neha.
Yes, sir.
Slides are changing, now it is visible. Understand means
from our side it is not changing, but those who are seeing from outside, they have told that it's changing.
okay. So should I continue?
Yes, sir.
Should I continue?
Sir, slide is not changing. You can unshare and share the slideshow from the screen. Yes, now it's perfect.
Now it's changing?
Yes, sir.
Fine. So now in the first slide, we initially discussed about the introduction part. Now we want to understand the labor pains. So labor pains is mainly two components. One is the visceral part of that, and the other part is the somatic pain. Visceral pain is more at the level of because of the disturbance of the peritoneum and the uterine contractions, and somatic part of the pain is more because of the dilatation of the cervix. So labor pain is mainly two components: visceral pain, which occurs during the early first stage and the second stage of childbirth, and somatic pain, which occurs during the late first stage and the second stage. So this is the pathway. So to understand where the pain is mediated, then only we can manage the pain. So the pain of labor in the first stage is mediated by the T10 to L1 spinal segments, whereas that in the second stage is carried by T12 to L1 and S2 to S4 spinal segments. Now it is a very important slide to understand what is the level of spinal cord, or we can say the level of the thoracic and the lumbar, as well as the sacral spinal segments where the pain is mediated. So from T10 to L1 in the first stage, and T12 to L1 and S2 to S4 in the second stage. So if we talk about the visceral pain first, visceral labor pain occurs during the early first stage and second stage of childbirth. With each uterine contraction, pressure is transmitted to the cervix, causing stretching and distension and activating the excitatory nociceptive afferents. These afferents innervate the endocervix and lower segment from level of T10 to L1 vertebrae. Somatic pain, this occurs in addition to the visceral pain described above in the late first stage of labor and also in the second stage. It arises due to afferent that innervate the vaginal surface of the cervix, and it manifests during the descent of the fetus, and during this active stage, the uterus contracts more intensely in a rhythmic and regular manner. So as we already have seen the pattern of uterine contractions, it starts, then it increases in the intensity, it increases in the duration, it increases in the frequency. So that also adds to the increasing pain, and the pain is at its most intensity after 8 centimeters of dilation when the cervix is about to reach full dilation. Now we have talked about the physiology of labor pains. Now in next part we are going to talk about the psychology of labor pains. In psychology of labor pains, a recent Cochrane review concluded that women who had continuous intrapartum support were less likely to have intrapartum analgesia or to report dissatisfaction. Other groups have suggested that an underlying anxiety trait can both result in a higher uptake of epidural analgesia as well as influence the analgesic effect of the epidural block. So this study, or you can say this psychological part of the labor pains, has you can say Government of India has taken the initiative of birth companionship, in which a birth companion of choice of the mother is allowed to be with the mother in the labor rooms. So that helps her to cope up with the labor pains and also with the process of labor. In India, we have common labor rooms in which 3 or 4 labor tables are there. So at times it becomes difficult to have her husband involved in the process. But corporate setups who have involved their husbands in the labor process also have verified that their involvement in the labor process has helped the mother to deal better with the labor pains. So that is the psychological part of labor pain. Antenatal education is also a very important part in giving mothers options available for labor pain and also how to cope with the labor pain. Whatever non-pharmacological techniques like breathing exercises or other exercises which we want the mother to practice during the labor to deal with labor pain are to be taught during the antenatal period, especially during the 3rd trimester. So antenatal education is also essential when obtaining informed consent from the mother and also involving the anesthetists in the educating the midwives and obstetricians. The aim is to provide good information to facilitate mothers to form realistic expectations and appreciate the limitations of certain methods of analgesia. Now, if we see a term is frequently used, tocophobia. Tocophobia is the fear of labor pains, or you can say the fear of childbirth. So, especially in primary mothers who have not given birth previously, the fear of childbirth or the fear of unknown, what to expect, how the labor will process. So, if during the antenatal period the mothers are counseled, then it will give them the realistic expectation what to expect, how much pain they will be having, and what are the options available for management of pain, what they can choose, or at what point of time they can decide to have analgesia for their labor. So that is a very, very important part of that. Now we move on to the labor analgesia and labor anesthesia. So as you all know, analgesics lessen pain without loss of feeling or muscle movement, whereas anesthetics relieve pain by blocking most feelings, including pain. Now, how they work? These pain relief medications work at mainly systemic level, regional level, or local level, as we choose them to be. Systemic medications affect the entire body. Local medications affect only a small area of the body, and regional medications affect a region of the body, like the region below the vest. So this is the way, depending upon the type of medication we are using, depending upon the type of effect we need a systemic effect or a local effect or a regional effect, we can choose the drug. Now, other question is, does management of pain during labor affect maternal satisfaction with childbirth? Now, it is a very important concern. all of us have walked through the labor room. जब हम लोग लेबर रूम में जाते हैं तो हम देखते हैं कि जो मदर है वो पेन में परेशान है, ठीक है। फिर आप मान लीजिए 10 मिनट या 15 मिनट बाद कुछ काम अपना करके वापस जब आए, then you see that mother is smiling and breastfeeding her baby. So though it was a painful experience, the positive outcome of birth of the baby and latching her to her body and breastfeeding her, the outcome has covered up all the feelings of pain. So in previous studies, however, as a consistent finding, labor pain is ranked high on the pain rating scale. We can see that McGill pain rating scale, labor pain is ranked very high, more than 40 score is there. When compared to other painful life experiences, the memory of this pain, however, is short-lived, and of participants who experienced severe pain in labor, 90% found the experience satisfactory 3 months later. This short-term memory may be related to positive outcome that often occurs at the end of the labor. Now, next question is, what is the intensity of labor pain? So the intensity of labor pain increases with greater cervical dilation. We see that the first stage is divided into the 3 parts: active phase, then the latent phase, active phase, and the transition phase. So mainly severe pain is in the transition phase when the dilatation is increasing from 8 cm to 10 cm. So the intensity of labor pain increases with greater cervical dilatation and correlates with the intensity, duration, and frequency of uterine contractions. Now, what is the indication for maternal analgesia or anesthesia? So one very important or generalized concept is maternal request is a sufficient medical indication for pain relief during labor. So mothers who require, who are requesting for pain relief is itself an indication for analgesia for labor. Others may be expectations of an operative delivery, maternal cardiac respiratory diseases, preeclampsia, trial of labor, obstetric complications, breech delivery. These may be other indications. In the further slides, we will discuss about what are the contraindications. So biggest and generalized indication is maternal request is a sufficient medical indication for pain relief during labor, and it is the right of the laboring or birthing mother to know about the options available for pain relief at the start or in the 3rd trimester of the pregnancy, as well as just when she is admitted to the labor room. Now we talk about the management of labor pains. So what is the ideal situation? So ideal situation is when the procedure is efficient enough to relieve pain but is not depressing the respiration of the fetus nor the uterine activity causing prolonged labor. So as we have seen, there are 4 P's. One is power, passage, passenger, and the psychology. So power and psychology are a very important part of the labor process, whereas the passage and passenger are more of the anatomical parts. So when we talk about the ideal situation, the pain relief should be such that it does not interfere with the health of the fetus as well as the health of the mother, and does not or do not prolong the labor process. Now, what are the factors that affect pain management? Now, we have seen that there are mothers who complain very much of pain when they have not entered even the active phase of labor. So, at times it may be judgmental. कई बार होता है कि जो वहां का मिडवाइफ से स्टाफ से वो थोड़ा जजमेंट यूज करते हैं कि आप ज्यादा रीड कर रहे हो, इतना पेन तो नहीं हो रहा. सो एज मिडवाइफ्स वी शुड नॉट बी जजमेंटल बिकॉज every individual has different pain threshold. So this is a very important concept. As midwives in labor room, we need to understand this, that every mother has different needs and every mother has different pain thresholds. So no judgment should be there कि देखिए आपके पास वाली मदर जो लेबर टेबल पे सो रही है वो तो चुपचाप सो रही है, आप इतना क्यों चिल्ला रहे हैं. कई बार ऐसी चीजें देखने में आती है, तो जजमेंट वहां पर यूज नहीं करना है बिकॉज that is absolutely normal. We have different pain thresholds as individuals. So what are the factors that affect pain management? First is pain threshold. Threshold of pain varies from patient to patient or mother to mother. some mothers experience severe pain, though the uterine contractions are relatively weak. In such cases, it is preferable to control the pain adequately. Second is parity, as already we have discussed. Priming gravidas receive more or experience more pain. So the multiparous woman need less analgesia due to added relaxation of the birth canal and rapid delivery. So both the things are there. Because of the previous birth, the birth canal is also relaxed and the duration of labor is also shortened. Then third very important thing that affects is the maturity of the fetus. So minimal doses of drugs are indicated while the fetus is thought to be premature to avoid neonatal asphyxia. अगर बच्चा जो है पूरा mature नहीं हुआ है, it is not crossed 37 completed weeks, then at times it is not advised because it may lead to neonatal depression or neonatal asphyxia. So these three things are important to be considered. Now, first to start with, we are going to discuss about what are the pharmacological analgesia for labor pain, in which we will discuss these under different routes. First is parenteral, then inhalational, regional, combined spinal epidural, continuous spinal analgesia. So first to start with the parenteral part, most commonly used is the pethidine. So pethidine is generally used in the first phase of labor and indicated when the discomfort of woman merges into regular, frequent and painful contractions. So as we see, as midwives in the labor room, we see when the initial starting of the contractions takes place, they are little irregular. As it progresses, it becomes regular, frequent and more in intensity or more in painful. So that is the time to administer the analgesics. So the initial dose is 100 mg. It is available in 100 mg per 2 ml. So 100 mg, 1.5 mg per kg body weight is given by intramuscular route and repeated as the effect of the first dose begins to wane. Agar mother ko lagne lagta hai wapas mother complains of pain, then it can be given without waiting for the re-establishment of labor pains. The side effects of pethidine to the mother are nausea, vomiting, delayed gastric emptying. So ranitidine should be given to inhibit gastric acid production and emetic effect is counteracted by the metoclopramide. So pethidine crosses the placenta and accumulates in fetal tissues. So it is very important that the fetal monitoring is also done. Fetal heart rate is also done. Madam has already given elaborate insights on the CST, contraction stress test, NST and all other fetal monitoring methods. Pethidine depresses respiration and suckling of the newborn when administered before delivery. So it is of choice as during the early first stage of labor. So first one was the pethidine. Other parenteral agents are meperidine, fentanyl, promethazine, phenargon. In the image you can see pethidine is available in the 100 mg per 2 ml. Then fentanyl 100 microgram per 2 ml is available. It may vary from place to place. Ideally, the dose for pethidine is 1.5 mg per kg body weight. Now, as we see that there are side effects, then there must be some antidotes. So, narcotic antagonists are used to reverse the respiratory depression induced by opioid narcotics. So, naloxone is given to the mother at 0.4 mg intravenous in labor. It may have to be repeated. It is given to the newborn 10 microgram per kg intramuscular or IV and is repeated if necessary when the infant is born with narcotic depression. So we have to be prepared for the resuscitation also if these opioid analgesics are given because they cross the placenta and respiratory depression in the newborn can also be seen. So after parenteral, we have the inhalational anesthesia. This is less frequently used in India, but around 60% of the cases it is used in the 60% of the mothers delivering in US and UK are using this inhalational anesthesia. Antanox is the most common, in which a 50-50% mixture of oxygen and nitrous oxide is the most widely available inhalation anesthesia in US. Despite its widespread use, studies have shown that when used in labor for short periods, it is not a potent analgesic, but does provide some analgesia and is safe for laboring women and their babies. So it is widely used in the US and UK, not frequently used in India. Now when to inhale, कब उसको अंदर खींचना है? So generally आप मदर को बात करोगे तो उसको जैसे ही पेन आता है उससे 20 से 30 सेकंड बाद उसको पेन का हाईएस्ट नाडर आता है. So a woman holds the mask herself and decides when she will inhale. It works best when a woman begins inhaling 30 seconds before the starts of the contraction. 30 सेकंड पहले अगर लेंगे तो उसका इफेक्ट आ जाएगा. Now what are the risks involved? In this you can see that a mask is used, and in this image you can see an Internox 50% oxygen, 50% nitrous oxide cylinders are ready-made available. Now what are the risks involved? Nitrous oxide is safe for the mother and the baby. Some women may feel dizzy or nauseated while inhaling nitrous oxide, but these sensations go away within a few minutes. Initial puffs में ऐसा लग सकता है, but धीरे-धीरे जो बाद में इसका जो ये डिजीनेस हो ये खत्म हो जाता है. अब in practice what we see is opioid analgesics की वजह से respiratory depression in the fetus was there, but these inhalational anesthetics do not have any respiratory depression in the newborn, so they are preferred for the second stage of late first stage and initial of the second stage. At that point of time they are preferred. Now third very important part is the regional or neuraxial anesthesia. When complete relief of pain is needed throughout the labor process, epidural analgesia is the gold standard, or it is the safest and simplest method of procuring it. So epidural is the gold standard when complete relief of pain is needed. But what are the limitations of this? Anesthetists are able to do or should do this procedure, and they should be available round the clock when it is in progress. This is the anatomy. We know that when we are talking about dura, it is above the dura is the epidural, in which the epidural anesthesia is given. This is generally reached around L3, L4 or below L4. In this image you can see. Now what is the procedure and what are main nursing part I will cover in this. So first is obtain informed consent. Informed consent is very necessary. It is the responsibility of the nurse and the anesthetist to nurse will witness it and anesthetist will take it. Ensure adequate venous access is there. Pre-hydrate with 500 to 1000 ml of crystalloid as hypotension is a side effect. Set up patient monitoring as follows. Blood pressure recording at baseline prior to administration of regional anesthetics. Then every 1 to 2 minutes for 15 minutes after giving a bolus of local anesthetic. Then at every 5 to 15 minute interval until the block wears off. Because hypotension is a very common side effect. So continuous blood pressure monitoring should be done at these intervals. Continuous maternal heart rate monitoring during induction of analgesia and continuous fetal heart rate monitoring is also very important. Help the patient assume a seated or lateral decubitus position. The seated position is preferred in very obese patients. The purpose is to have a good access to the vertebrae. Clean the lumbar area with appropriate antiseptic and drape the area. Palpate the lumbar spinous process and choose the widest interspace below the L3. Just to show it, I have used this image. So this is the Tuhi needle, Tuhi epidural needle, in which markings are there. And after this needle is inserted, this needle is removed and catheter is placed in the epidural space. Then this catheter can be taped and analgesia can be given through this in the epidural space. First, a test dose is given. After the administration of test dose, movement of the feet is assessed. Movement of the feet ensures correct placement of the catheter in the epidural space. Sensation to cold or pin prick is lost, but the movement is there. So very important part to assess whether it is rightly placed or not is the movement of feet is there, but the sensation part is lost. The sensation part is lost, but the motor part is intact. So sensation to cold or pin prick is lost, but the movement is there. That is a very important indication. So if the test dose is negative, that is absence of tachycardia is there, then inject the anesthetic in 2 to 3 small boluses to achieve a cephalate sensory level of approximately T10. Initial block options include bupivacaine 0.125 to 0.25%, 10 to 15 ml. Then at times other cocktails can be used in which fentanyl can also be added, or other opioids can also be added to these. Now, what are the nursing responsibilities? So, epidural analgesia as a general rule should be given when labor is well established. It is preferred that it should be given when the mother is dilated to around 4 to 5 centimeter dilatation. So, epidural as a general rule should be given when the labor is well established. Maternal hydration should be adequate with normal saline or crystalloid infusion prior to commencing the blockade. The patient's blood pressure, pulse, and the fetal heart rate should be recorded every 15 minutes interval following the induction of analgesia, and hypotension, if occurs, should be treated immediately. The woman is kept in semilateral position to avoid aortocaval compression. So these are the nursing responsibilities. Now, what are the advantages of regional anesthesia? As we have already said that it is a gold standard, it is the most commonly used analgesia in labor. So what are the advantages? The patient is awake and can enjoy the birth time. So every woman want to feel it, how it feels to give the birth to the baby. So epidural allows the mother to be awake and experience the birth, at the same time gives relief from the pain. Newborn Apgar score is generally good, so no respiratory depression is seen. Lowered risk of maternal aspiration is there, and post-operative pain control is also better. These are the advantages of regional anesthesia. Now, what are the contraindications and complications of epidural? To see what are the contraindications, in indications we have already seen. First indication is the mother's request for pain relief. Then other indications can be like any PIH, hypertension is there, any expectation of having a instrumental or operative delivery, or you can say breech presentation. These can be other indications. So what are the contraindications? Any bleeding disorder or any coagulopathy is a contraindication. Supine hypotension, hypovolemia, neurological diseases, any spinal deformity which can interfere with the axis, then any skin infection at the injection site is a contraindication. Now, what are the complications that can be expected? Complications can be hypotension due to sympathetic blockade. Participant should be well hydrated. We have already seen. Then post-spinal headache, injury to nerves, convulsions, pyrexia. Now, nowadays, ultrasonic help also is taken to access the epidural space. Now, what are the recent advances in neuroaxial analgesia? जब हम बात कर रहे हैं epidural block की और topic में ये है कि what are the recent advances? So, what are the recent advances? First is technical advances. Technical advances में mainly आप देखेंगे combined spinal epidural analgesia. हम आगे पढ़ेंगे. Combined spinal epidural में क्या है कि loading dose is set in the spinal or in the subarachnoid space. Then the maintenance dose is in the epidural space. Continuous spinal analgesia using microcatheters. Microcatheters are being used. Ambulatory epidurals. Ambulatory epidurals में mother can ambulate. Concept of MLAV and MLAD. MLAV is the minimum loading dose and volumes. Low dose and ultra low dose epidurals. Then pharmacological advances. Other pharmacological agents also have been tried. Though bupivacaine is the drug of choice, ropivacaine, levobupivacaine, newer opioids, sulfentanyl, rafamidanyl, adjuvants, guanidine, and neostigmine. So we can see that only bupivacaine or cocktails can also be given in which the opioids or adjuvants can also be added. If we talk about the technological advances, availability of ultrasound to facilitate localization of epidural space, minimizing failures. So this is very important. And patient controlled epidural analgesia also is there. In patient controlled analgesia, patient has a switch in his or her in her hand, so she can press it when she feeds. So already limits is set, so access cannot be given. Then newer insights into the myths and controversies associated with neuraxial techniques. By research or by evidence, it has been established that the effect and timing of epidural on cesarean section. Earlier, it was seen that it was a myth, or it was much talked about that with epidurals, the incidence of cesarean section may increase. But by the research or the RCTs and the Cochrane reviews, it has been proved that it does not increases the likelihood of a cesarean section. Then maternal neonatal outcomes also are not compromised. Breastfeeding can be started. Withholding the dose in the second stage of labor is not required. Then intrathecal placement, if by mistake it is placed in the subarachnoid space, then or the catheter tip is broken, then the CT scans and MRI can help to identify these. So these are some specific to neuraxial analgesia. These are some recent advances, in which main are the decreased doses, availability of newer agents, support by the ultrasonography for access are the main parts. Then other part is the pudendal nerve block. Pudendal nerve block is a safe and simple method of analgesia during delivery. It is mostly used for forceps and vaginal breech delivery. It has much to do with the somatic part of pain, which deals with the lower perineal part. So simultaneous perineal and vulval infiltration is needed to block the perineal branch of the posterior cutaneous nerve of the thigh and the labial branches of the ilioinguinal and genitofemoral nerves wide supra. This method of analgesia is associated with less danger both for the mother and for the baby than general anesthesia. So that is the pudendal nerve block. In the next slide, we will see the image. So the identifying feature or identifying landmark for giving this anesthesia is the ischial spines. So transvaginal route is generally preferred route. Transperineal route can also be given, but transvaginal route is the preferred route. A 20 ml syringe, 115 centimeter, 22 gauge spinal needle, and about 20 ml of 1% lignocaine hydrochloride are required. The index and middle finger of one hand are introduced into the vagina. The fingertips are placed on the tip of the ischial spines. So, first of all, we have to identify the ischial spines. Above the ischial spines is the ligament, that is the sacrospinous ligament. This sacrospinous ligament is to be pierced. The needle is passed along the groove of the fingers. In the image, you can see the groove of the fingers and guided to pierce the vaginal wall on the apex of the ischial spines, and thereafter to push a little to pierce the sacrospinous ligament just above the ischial spine tip. After aspirating to exclude blood, so that is a very important part. It has to be aspirated like we do in the IM also. To exclude the blood vessel, about 10 ml of the solution is injected. The similar procedure is adapted to block the nerve on the other side by changing the hands. So that is the procedure for pudendal nerve block. Mainly its indication are in the second stage of labor, when the baby is about to deliver, or if the use of forceps is required, then it is given. Then spinal anesthesia. Spinal anesthesia generally more we are using it in the LSCS in our OTs. So spinal anesthesia is obtained by injection of local anesthetic agent into the subarachnoid space. It has less procedure time and high success rate. Spinal anesthesia can be obtained by injecting the drug into the subarachnoid space. So epidural was above the dura and spinal is in the subarachnoid of the third or fourth lumbar interspace, with the patient lying on her side with a slight head uplift. I am sure the students might have seen it in the OT. The blood pressure and respiratory rate should be recorded every 3 minutes for the first 10 minutes and every 5 minutes thereafter. Oxygen should be given for respiratory depression and hypotension. Sometimes vasopressor drugs may be required if a marked fall in blood pressure occurs. It is used during vaginal delivery, forceps, ventos, and cesarean delivery. Though it is written like that, but most commonly it is preferred for LSCS only. Now other is the combined spinal and epidural analgesia. This is a recent advancement in which epidural as well as spinal anesthesia is given in a combined way. So an introducer needle is first placed in the epidural space. A small gauge spinal needle is introduced through the epidural needle into the subarachnoid space. So what happens is initially a needle is placed in the epidural space under which or in which another needle is inserted, that it goes to the subarachnoid space, that is known as the needle through needle technique. A single bolus of 1 ml of 0.25% bupivacaine with 25 microgram of fentanyl is injected into the subarachnoid space. So to start with, spinal part is given. Now once the loading dose is given in the spinal part or the subarachnoid space, the spinal needle drug. So at times we use the term maintenance dose. So that can be used for the further. So the method gives rapid and effective analgesia during labor and cesarean delivery. Now next is the infiltration analgesia. ये आपने बहुत commonly देखा होगा while we are using the episiotomy, we are using for the local anesthetic. So perineal infiltration for episiotomy. Perineal infiltration anesthesia is extremely used extensively used prior to episiotomy. A 10 ml syringe with a fine needle and about 8 to 10 ml of 1% lignocaine hydrochloride are required. The perineum on the proposed episiotomy site is infiltrated in a fan-wise manner. We will see in the image. Fan-wise manner, starting from the middle of the fourchette. Each time prior to infiltration, aspiration to exclude blood is mandatory, that is routine. Episiotomy is to be done about 2 to 5 minutes following the infiltration for the effect to take place. This is the fanning technique by which it is given. So every time it is injected, it should be aspirated and checked that it is not in the vessel. Now another recent advancement is the patient controlled analgesia or PCA. Narcotics are administered by the mother herself from a pump at continuous or intermittent demand rate through intravenous route. So patient controlled analgesia, mother has the control over the administration, though it is kept by the highest level of dose. It cannot increase that level of dose. So total dose is limited as there is a lockout interval. This offers better pain control than high doses given at a long interval by midwife. Maternal satisfaction is high with this method. Now in this image you can see mother is having a knob in which she can press. So maternal satisfaction is high as this gives the mothers better control over her process of delivery. And drugs commonly used are pethidine, meperidine and fentanyl. Okay, so in these slides we discussed about the pharmacological parts. Now in very brief, I have almost around 2-3 slides more are left. So what are the other complementary and alternative therapies for pain management in labor? So we saw about the non-pharmacological part. Now we are going to see about the non-pharmacological part. So many mothers try to avoid invasive and pharmacological methods of pain relief in labor and seek complementary therapies which have minimal side effects and are easy to administer. So mothers at times feel that pharmacological वाला नहीं चाहिए, कोई non-pharmacological technique हो तो वो बताइए जिससे कि pain भी कम हो जाए और कोई artificial agent हमको use ना करना पड़े. So in this, nurses and midwives have a very important role. So a systematic review of randomized control trials comparing water immersion during labor with no immersion were concluded that laboring in water is in the first stage reduces the use of analgesia and reported maternal pain without adverse outcomes on labor duration, operative delivery or neonatal outcomes. So in this study, in this RCT, review of RCTs, it was seen that it decreases the labor pain. Also, no adverse outcome was seen. So water immersion, for example, recently I was seeing a birthing center inauguration of the AIMS Bhopal. Choitran College also has, St. John's also has, where the midwives are needing the birthing centers in which they have the facilities for water birth. So water immersion may be associated with increased uterine perfusion, shorter labors, and a decreased need for augmentation. The associated feeling of weightlessness also adds to comfort and allows for easy change of position during labor. Warm water, as well as inducing muscle relaxation and reducing anxiety, may also decrease the release of catecholamines and stimulate the release of endorphins that makes the mother feel good and decreases the stress of labor. I am not going in much detail of other methods. Other methods include continuous one-to-one support, massage in the lower back that can be explained by the midwives to the birth companion how to massage the lower back. Then breathing techniques, Lemay's method of breathing, acupressure, TENS, hypnosis, music therapy, birthing ball exercises. These are other non-pharmacological techniques which also can be used to manage the pain of labor. Now, this birthing ball technique, our MSc student, one of our MSc students, Sujata, took a research study for this birthing ball technique in which she saw the effect of birthing ball exercises during antenatal period. So our nurse midwives in the UG level, at the PG level, can also undertake such studies. Though we have limitations, we cannot go for the pharmacological part, but we can go for the non-pharmacological part, and we can undertake such research projects in which we can see the effect of these non-pharmacological techniques of labor pain, how they are effective. Now, last few slides. Now, summary of analgesics in labor. Now, what are the evidences which are available for different types of analgesia? These are the 3 levels of evidence. First is, which are shown to be effective, is the epidural, combined spinal epidural, and continuous one-to-one support. So even continuous one-to-one support also has been found to be effective, has effective evidence of managing labor pain. So the importance of antenatal birth education and the importance of birth companionship, and also explaining what is the role of birth companion during the process of labor, is a very important midwife initiative. Like from the starting, there may be some interventions which were not allowed by the midwives, but at this point, in the concluding side, we can see that continuous one-to-one support has been found as an effective intervention to manage labor pains. So as midwives, ourselves can provide one-to-one support and also can educate the birth companion who are with the mother for better management of labor pain. So epidural, combined spinal epidural, and continuous one-to-one support have been has sufficient evidence and has been found effective. Little bit evidence or maybe effective for music assisted relaxation therapies, birthing ball, upright posture, sweating position, water immersion, nitrous oxide, relaxation techniques, massage, acupressure, non-opioids, sterile water injections. Then patient control analgesia. This may be have little evidence or may be effective, and insufficient evidence are available for TENS, biofeedback, hypnosis, aromatherapy, and other parts. So the concluding slide, while a number of pharmacological and non-pharmacological options exist for labor pain, epidural anesthesia remains the gold standard for severe pain. For severe pain, those mothers who do not want to experience pain and also want to have the birthing experience can go for epidural anesthesia. And one very important part is the one-to-one contact or birth companionship is a very important birthing intervention by midwives to address the labor pain. This was the image I showed. The purpose of showing this image was because many MSc nursing students will also be attending this. So this can give you a thought to undertake research projects in which the non-pharmacological methods of relieving labor pain are there. You can take only one intervention. You can take and compare 2 or 3 interventions. So that can be good studies. Although questions will be given in the chat box, but still if you have queries, this is my mail ID. The questions can be shared on mail also. Again, I express my heartiest gratitude to the organizers for giving me an opportunity. Thank you very much.
Thank you so much, sir, for the informative session, sir. It's time for the discussion. If anyone wants to ask any questions, they can write into the chat box. Okay. So sir has explained nicely regarding the physiological pain and psychology of labor pain, antenatal education, labor analgesia and anesthesia, how it works, detailed management of the labor pain and nursing responsibilities, pharmacological analgesia for labor, new recent advances into the labor analgesia like PCA and all. Thank you so much, sir, for live interactive session. Uh, we are very glad that you have joined us and given the lecture on labor analgesia. Sir. Thank you so much, sir.
Thank you very much.
Okay, sir.
May I leave now?
Yes, sir.
Okay, thank you so much.
Thank you so much. Dear participants, now we are having the lunch break. So we'll resume our conference by 2 p.m. So kindly join it before the 10 minutes to avoid the technical hurdles. Thank you so much for your presence.
Hello, ma'am. Are you there?
Yes, ma'am, I'm there. Good afternoon.
Okay, good afternoon, ma'am. So, good afternoon to one and all present here. Once again, welcome to today's e-conference on exploring the advanced practice in maternity. I, Ms. Seema Boresa, Assistant Professor, Dinsha Patel College of Nursing. I heartily welcome you all for today's conference. I welcome our today's resource person, Mrs. Martha Rao, Associate Professor, Dr. D.Y. Patil College of Nursing, Pune, Maharashtra. I welcome you, ma'am. Now, moving towards the scientific session 3, advanced different methods of delivery. Before the starting presentation, we will have some glimpse of a career in nursing profession. Now, I would like to introduce our today's presenter, Mrs. Martha Rao, Associate Professor, Dr. D.Y. Patil College of Nursing, Pune, Maharashtra. Ma'am has completed post-certificate Bachelor of Science in Nursing in the year 1998 with Shivaji University from Miraj Medical Center, Wellness Hospital, Miraj. Ma'am has postgraduated in Obstetric and Gynecological Nursing in the year 2010 from Dr. D.Y. Patil Deemed University, Pune. Ma'am is pursuing PhD in Nursing from D.Y. Patil Deemed University, Pune. Ma'am has 3 years of clinical experience at Wellness Hospital Miraj, Shahpur Thane and Civil Hospital Alibag. Ma'am worked as a principal for 6 years at Anand Medical Foundation Nursing Institute, Kuruli, Pune. Ma'am has guided many UG and PG research projects and also published research papers in various national international conferences. Ma'am has organized various workshops, conferences, and seminars. Ma'am is presently working as an associate professor since 2018 at Dr. D.Y. Patil College of Nursing, Pune, Maharashtra. Once again, we welcome you, ma'am. So now I hand over the session to ma'am. Over to you, ma'am.
Thank you. Please allow me to share my slide.
Yes, ma'am.
Okay. A very good afternoon to everybody. Am I audible? Am I audible, ma'am? Can you see my slides?
Yes, ma'am.
Okay. At the onset, I'm very happy to be here as one of the resource persons, and I would take this opportunity to thank the Dinsha College of Nursing and Dr. Virendra sir, a good friend of mine. And also I would like to appreciate Madam Neha for being in touch with me and inviting me to be the resource person. Since morning, I have been with you all, and the other colleagues or other eminent resource persons have done excellent job in presenting the topics which were given to them, and it was very interesting, and they did justice to their topic. I would also like to thank Himanshu sir for laying the platform for my today's topic, because in his last part, he almost tried to say what are the other things which I would be dealing today this afternoon. So we start with our today's session, and I hope everybody is awake after the post-lunch session. And this area is very difficult to keep. The time is very difficult to keep everybody awake. And I'm sure everybody is going to be awake and listen to my lecture. And this will definitely be of good of help to them. Okay. Like if you have to see, like whenever we think of a birth process, we always have to have a very executed plan which needs to be done. In today's world, if you see, birthing or the delivery is considered at a very as a risky procedure. But if you were to ask me, I would say this is a very pleasant experience, and this has to be maintained into that. And definitely a proper planning has to be done, and the proper execution of plan has to be done, so that the things are taken under control and we do not have any complications which we will face. So the preparations is very important. Along with the other methods, we know that what other methods we could be aware of it, and how we could prepare ourselves for that. So as health professionals, we need to know what are the various methods by which we can educate the people and how we could prepare them. Nowadays, we consider, like previously we used to have home birth, and nowadays we are concentrating on the institutional birthing, and people appreciate the birthing centers. It's not the old traditional techniques, like we have the birthing suits which are available, and they are like a home-like atmosphere, which is giving a very soothing and comforting atmosphere for the woman, and she gets mentally prepared to it, and she doesn't feel very much odd, or she is not scared of the setup for the delivery. Like here today, I would like to mainly teach you about what do we mean by respectful maternity care in nutshell, also to see the traditional methods of delivery, and also to discuss some of the advanced methods of delivery or childbirth, and also the various facilities for advancing birthing methods which we need, are the centers which are available for this advanced birthing centers, or also to check out some of the research studies which, hello?
Sorry, ma'am.
Yes.
Ma'am,
Yes.
kindly do the slide share. It's not moving.
I have actually shared the slide. 1 second. I'll have to. Okay, are you able to see the slides?
Yes, ma'am.
Okay,
Not
thank you so
yet,
much.
ma'am.
I have done the slide share, ma'am.
Yes, yes.
Are you able to see now?
Okay, ma'am.
Okay, so as I said, we are going to see basically some of the aspects of today's lecture is mainly about our e-conferences, respectful maternity care, the just concept. I'm going to just introduce it and look into the traditional methods of delivery, some advanced methods, few of the advanced methods, and also which are the various facilities or centers for advancing birthing methods, and what are the various research studies which are carried out. Like, as I said, we whenever we discuss about birthing process or the delivery, we always have a typical picture of a labor. I remember those days when we had started learning midwifery in 93 and 94. We were like, we did not know major other methods rather than we were very much focused towards the midwifery. And that image of the delivery process is different in our mind. And now when we see towards the latest or advanced procedures or advanced concept of midwifery, that really has changed totally. Now, I would just like to just revise, like, what is respectful maternity care? This is basically a very important concept which is given by the WHO, basically regarding the universal rights of children-bearing women. Into this, if we have to see, mainly it concentrates on the respect for women's autonomy, her dignity, her empathy, her privacy, her confidentiality, feelings, her choices, and preferences, including very important part that is which is introduced is about the companionship during the maternity area, and also the continuous care during the labor and childbirth. If you were to ask me, previously we used to not allow any relatives to come inside the labor room, or not even to the front area. But nowadays the companionship or the use of or need for a companion has been evolved, which is a very good welcome, and people have appreciated that concept. So, and when we think about that respectful maternity, we need to know, to understand the dignity of a woman and the mother, and try to give her that respect, whatever is her right, and accordingly treat her, and not giving her any abusive words or giving any physical abuse, or all wrong practices have to be stopped if at all they are there. Now, if you have to see certain advanced or different methods of delivery here, I would just like to revise about the normal vaginal delivery and vacuum extraction, forceps delivery, Lamez method, Bradley method, water birth method, Alexander technique, hypnobirthing, and the cesarean section. These are the points which I will be covering in my today's presentation. As I said in the beginning, when we started with our midwifery training, this was the like vaginal delivery was the only the birthing process which we knew about it. And later on, we started with the other methods. This is the safest method if you have to see. And this is, there's a disturbance. Hello? Vijay sir, can you just, sorry. Okay. So I was discussing about the vaginal delivery method. Like, this is the this is the commonest method. And I would say this is the best method of delivery. And you know that this is a type of birth through which woman's birth canal, the vaginal delivery takes place. And this is the most common way of childbirth and is very useful. It involves mainly, we all know about the 4 stages and what happens in those 4 stages and how the baby is born. And we already heard our previous speakers speaking so much about the normal labor and also about the various means how we could reduce the pain. And he rightly said about the various types of pain. And basically my purpose is mainly like here in this, we as nurses, when we are into the process of helping our clients or mother. Yes.
Slide is not changing. So please, first of all, stop the sharing of the slide.
Okay.
And again share the slideshow.
Okay, I have stopped it.
Voice is not audible.
1 second.
First, you can do the slideshow of the PPT and then share the slideshow. Directly slideshow share.
Okay. One second.
Madam, voice is not audible. Please unmute.
केला पण स्लाइड शेअर परत करायला सांगितलं. हे काय डिसेबल पार्टिसिपेंट स्क्रीन शेअरिंग काय करू? ओके.
This is also again, you are sharing the PPT, but share the slideshow.
Ma'am, is the slide visible now? Hello? Hello, ma'am.
Yes, madam. It is visible, but it is not in PowerPoint mode.
From my side, I'm doing that, but I have already shared, like, the slide share. Hello, ma'am. Hello. 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 Hello, ma'am. Is it visible? Hello.
Hello.
Hello, ma'am. Are the slides visible?
Yes, slide is visible, but it is not again slideshow. So it will not change. So first to stop the slide share.
I did
share
that. I did that. I did that, ma'am.
Okay, okay.
Can you see now?
No, ma'am. Change the slide. I will
Okay.
respond.
Now, can you see the change of slides?
No, no, ma'am. Slide is not changing over here.
Okay.
First do PPT slideshow and then share the slideshow.
PPT slideshow. One
First
second.
PPT slideshow, do it, and then share the screen and then share the slideshow directly. Stop sharing the screen right now. Okay.
Okay.
Now do the slideshow of the PPT.
One second. Slideshow.
Directly do slideshow on your PC and then again share the screen.
1 second. Yes, after this.
Now share the screen and in that select that slideshow PPT. It will be visible slideshow PPT. Two PPTs you are going to see on your screen. And select the slideshow PPT and then share it. Perfect.
Now can you see?
Yes.
Yes?
Yes, yes. We can
Okay.
see now. You can continue.
Okay, ma'am.
Okay, okay. Thank you.
The next topic.
Ma'am, your voice is not audible. Unmute, please.
My slide is not moving actually.
Yes, slide is okay, and now your voice is also audible.
That slide is not moving.
Yes, slide is not changing. Change once. Yes, your slide is changing now. You can start, madam. Please unmute first.
I just had cough 1 minute, so I just.
Okay.
Okay. Now are you able to see, ma'am?
Yes, yes.
Yes. I'm sorry for all the technical problems and all the disturbances. So we were with the vaginal delivery, and then we said that this is the safest method, or you can say this is the best method if you have to say about the vaginal delivery. Then, as I was discussing, that like initially we used to have maximum deliveries which we conducted were in the vaginal deliveries, and then we used to conduct the vaginal deliveries in the lithotomy position. But now if we have to see the latest trends, what we can see, the deliveries are conducted in various different positions, which are definitely helpful for the birthing process. So like one of that, is upright birth benefits. So what you can see here, because of this, you can find that there will be available space in the pelvis, which can be increased by about 28 to 30%. Also, you can find that contractions can be more effective in this various upright positions. Then 23% of they need medical assistance, and you can find also the babies are like 54% almost become less distressed, or we don't have fetal distress cases more. This shorter labor is almost about 29%, and you can find that there can be reduction in the emergency cesarean sections. Also, the 21% reduction in the episiotomy rates are there, because nowadays we believe that we are not supposed to be taking episiotomy unless it is emergency. We are encouraging and emphasizing more on normal labor without episiotomy. Also reduce need for epidural. So according to this, you can find there are various advanced positions which have come in the normal birthing process or of the vaginal deliveries. You can see in the picture here that there are various positions, like if they are sitting in a sitting or a study chair, the edge of the bed or a birthing ball. As sir said previously, there are various research studies which are called out or which are done, where you can find that this added things are going to help you for the birthing process. Also, like leaning forward, and then if you have to see, like very important aspect, like what we are, sorry. This is a problem. Okay, sorry again, once again. So as I was telling that there are different positions which we are trying to use in the birthing process in order to make it very easy for the mothers. Nowadays, like you must have seen, we are emphasizing on the squatting position, the standing position, and the kneeling down positions, or which the mother is like almost, we are trying to teach her in the previous phases. And then we are trying to see that they are emphasized. Also, you can find that benefits of vaginal delivery. Basically, it helps in, we all know that because of vaginal delivery, there will be shorter hospital stays. There will be reduced lower infection rates. And also we can find the babies born vaginally will have a lower risk of respiratory problems. Also, you can see that there will be less chances of abdominal surgery. And we can find that we are able to, the mothers will be benefited because of all this various benefits of the vaginal delivery. There are certain disadvantages of vaginal delivery, like if we have to say, we know about it, but just to rail, there can be chances of tear of the perineum, the bleeding from vagina due to a tearing of perineum can be there, and many times the vaginal delivery may not be recommended. There are certain complications of vaginal birth. You can find that when we see that there is a overstretching sometimes, and because of the soft stitches, soft tissue can be stretched out, and you can find that there are chances small severe tears can occur, because of which the muscles can be little weakened, and we can find the mother will have sometimes temporary or chronic pelvic pain. Also, there can be persistent pain or perineal pain or vulval pain sometimes. So after seeing through this vaginal delivery, we can find that there are now various assisted vaginal delivery methods, and we are aware of most of them. Initially, when, as I was telling, after vaginal delivery, the second things what we used to have in previous days is, like we used to think about the cesarean sections, and cesarean sections in those days were mainly about, there used to be emergency cesarean sections, but now we have other assisted measures also which we can find, and this has to be planned in various in advanced methods. Here, if you see, I would just like to revise, there is assisted methods. In that, there are vacuum extractions. And in that, we can find that in this a soft cup like structure which is there, which can be attached to the head of the infant while it is in the birth canal, and we are applying, we are creating a suction, and then we are trying to facilitate the delivery. We all know about vacuum extractions, and you must have seen that this is like very useful, and nowadays the vacuum extraction use has been reduced to a greater extent. It also has assisted birth option, like there are lower risk of cesarean section because of this. Also, you can find there can be some minor scalp injuries or sometimes serious due to some problems or complications which can occur. If you have to see, can you just on a lighter note, if you go back to and see, if you go back and see and remember one of the incidents of Three Idiots movie where Amir Khan tried to deliver the sister of Kareena Kapoor with the help of the pump, whatever which we had. So it was almost, he used the mechanism of vacuum extraction. The second assisted method which we can use is forceps delivery. In this forceps assisted delivery, mainly we are using curved instruments which are there. Mainly it will facilitate the progress of the infant in the birth canal. Forceps are we are not using it in the bridge presentations, and you can find mainly these are used to pull down the baby's head in the following cases when the anesthesia has slowed down the progress of labor, or when the fetus is in distress, or hemorrhage threatens the life of a child and the mother. And also you can find that forceps delivery has various benefits to it. It will help us in the delivery can be achieved in a faster way. Their rate of successful vaginal delivery is greater, or also you can use to rotate the fetal head into the right position and facilitate normal delivery. If you have to see, there are certain disadvantages of the using the forceps. There can be fetal scalp injuries like cephalohematoma or following the use of that. And also you should see that there can be certain complications which can be seen with the use of forceps delivery. There can be the risk of serious birth injuries is minimum in the forceps delivery, but sometimes there can be permanent birth injuries also. And there is a technique of using, and there should be a proper skillful person to use this vacuum and forceps delivery. Then now moving on to the topic which is given to me, like for sir, already the previous speaker has introduced and he laid a platform for this. And now we are into a method like where we want to have a delivery or a birthing process which is of minimum or with the no pain technique. And we also would like to say that every person is trying to see how the labor process can be safe and how it can be faster. And that is the main purpose of this. Now, in this method, here I would like to tell you about the Lame's method of delivery or birthing process. This was introduced by Dr. Fernandez Lames, who developed this process or who developed this method. And it was done in Russia for using the psychoprophylaxis. As you saw, sir told about the visceral, somatic, and the psychological pain aspect. So you can see in this, mainly we are concentrating on the somatic and also on the psychological aspects of pain in various methods, which I will be dealing about it. In this, you can find this method is mainly used for distraction during the contractions to decrease the perception of pain and reduce discomfort. And this is a relaxed way of giving birth. And we are trying to see that how we are voluntary involving the mother in giving her this technique. Like we want her to have a relaxation of the abdominal muscles through proper breathing in order to increase the oxygen intake and distract the mother from labor pains. So it's a distraction during the contraction so that her labor pain is, perception of pain has been reduced. In this Lamés method, we see that the woman is taught to replace this response, taught about this. And she is mainly taught to replace her thoughts of restlessness, fear with this type of breathing method. You can find there are various exercises which are taught in order to strengthen the abdominal muscles and also to relax the perineum. Here, there are childbirth classes which are taken for Lamés classes. And then this will definitely help to increase the confidence of the mother, and it will help her to give the birthing process in an easier manner. Now here in this, if we can find how do we go about, there are certain things which we should know about the Lamés method. It is like, let labor begin on its own. As I said, let it be voluntarily, and walk, move around and change positions throughout labor. Bring a loved one like a friend or a doula or a continuous support, like what we are speaking nowadays about the companionship or a companion during the labor process. Also, you can see avoid interventions that are not medically necessary. Like we said, like we are, the morning session we learned, like there are so many pharmacological ways of reducing pain and increasing contractions and otherwise. But here we are trying to see, like without use of medications or without giving less trouble to the mother, in what way she can support her own self and try to gain the wonderful experience of childbirth. Avoid giving birth on your back. And that's where the different positions have come. Like we are trying to help her to attain the squatting positions, the standing up positions, where it will help her for a proper push-up. Keep mother and baby together, and it's best for mother, baby, and also for the breastfeeding purpose. There are certain benefits of this Lamés method. If you see, this training is given, as I said, and it prepares the mother and her partner to deal with the symptoms of labor and deliver it naturally. The breathing and relaxation techniques which are taught here, they reduce the perception of pain and keep labor moving smoothly. This also, there's this course which mainly helps the couple to be prepared with whatever like they expect, and also for the future what they are going to be doing in a few weeks together. There are certain disadvantages, like, here Lamés method, it will take little longer duration to learn the technique of it. Also, the couple needs to plan and attend those classes which are taught. And this method starts mainly in the second trimester of, this training starts mainly in the second trimester of pregnancy. There are certain topics which are covered in Lamés technique method. Like basically, as we said, the progress of normal labor, the delivery and the postpartum period, pain techniques such as massage and various relaxation methods, or also you can see how they can communicate and clear their doubts, breastfeeding, various like how to live about a healthy lifestyle. And these classes are mainly, they're taught in small groups so that individual attention should be given. And it is mainly almost 10 to 12 couples can be there. And the instructions which can be about 12 hours of instruction or topics. These are few topics which are taught, but definitely it's a package. And you can find that everything has to be taught well in advance, so that before the labor process, the mother is aware about the technique, and then the actual Lamés can be practiced during the labor. Then here, the second method which I have seen is about the Bradley method of delivery, or you can say the name it suggests, husband coached childbirth. In this, if you can find, this was developed by Dr. Robert Bradley in the late 1940s. This method helps women to deliver naturally with few or no drugs. Here in this, you can find this method is mainly focusing on preparing the mother for a natural childbirth coached by her partner. And here we are trying to see that how the mother can be helped for an unassisted vaginal birth without any medication. The name, as it suggests, it's with the help of a husband coached childbirth, you can find that it can be, the coach can be any significant others like a friend, a mother or a sister or an aunt or a grandmother or the husband, or mainly the concept of like, they should be there as a support system for them. They should be there for leading them and for guiding them. Also, the support system has to be for caring and giving them, help them to gain their confidence. So you can see that this is like what is come up and which is very much good, so that it would be helpful for the birthing mother. There are various benefits of this Bradley method. This method is mainly beneficial to prepare parents for unassisted births, where they don't want to go take any other chances. It helps the couple to be prepared with techniques to reduce the perception of pain. They stay relaxed through the natural and unmedicated childbirth. They're able to rely on each other. They're able to show that confidence and faith on each other. Also, it teaches the couple about things they need to know and to take care of themselves as new parents and what they expect when the infant arrives. There are certain disadvantages, like if those couples, they say like, we don't want to go for any other method. So like without, sometimes there can be a need of the other methods, which they are like, not ready for it, because they feel we are there for each other and we don't need any other things. Also, you can see this training of this method can also be started from the second. Hello?
Yes, ma'am.
Because in between I was disconnected. Again, I think I'll have to do share slide. Are you able to hear me, ma'am? I think the network here is. Hello?
Yes, ma'am.
Are you able to hear me?
Yes,
Yes, ma'am.
Okay, because I was not able to in between, I was just out. Okay, so as I was saying that there are various topics which are taught here, like, about healthy lifestyle choices, then about relaxation techniques for use during labor. Then there are also rehearsals which are taken. Then also you can find there are, they're teaching there about the postpartum care.
Slides
Hello?
are not visible.
Yes, now?
No, ma'am.
So much of technical problem. 1 second, ma'am.
Hello, ma'am.
Ma'am, can you share this slide from your side?
Okay, ma'am.
You have to stop it. You stop for us. Did this one? Hello? Hello?
Hello, ma'am.
Okay.
Ma'am, wait for few minutes.
I'll just try till then.
Okay, ma'am. Yes.
The meaning is
Hello, ma'am.
again, there's a problem. I'm not able to share. I have done slide share.
Hello, madam. We are doing
Hello?
from our side. Kindly wait for 5 minutes.
Okay.
Yeah.
Hello.
Yes.
It is visible?
Yes, ma'am. Visible.
Okay, ma'am, continue.
But have you done slide share, ma'am?
Yes, ma'am.
Okay. Just can you go to the water birthing?
Oh, okay, ma'am.
Yes, ma'am. Thank you so much.
Okay, ma'am.
So previous to this, we were seeing about the Bradley. Sorry. Am I audible now? Hello? Am I audible, please?
Yes, ma'am.
Yes, I'm very sorry for all the disconnectivity and the problems which are coming here. So as we were discussing about the Bradley method, or as I said, it's a husband coach method, where there are classes in which are taught like what they are supposed to be preparing themselves for the childbirthing process which is supposed to come. And this is the greatest advantage for the mother. Like if you see previous days, husbands, don't forget, even nursing, male nurses were also not allowed to come, and they were not doing midwifery. Those they used to go for operation theater and psychiatric nursing. Now it's a great thing, like companions are being allowed and husbands are also being there as a support system for the women. Now the other methods what we can see, and already sir discussed in brief about this, like water birthing method which is come up. And if you have to see about water birthing method, in this is a method like where the delivery will take underwater, or the mother can get she goes in the a tub which has warm water, and in this you can find that there can be different positions which can be taken. And if the mother wants, like if there is a need for the delivery, she can also come out and get the do the birthing process. Here the woman, she chooses the water births because it can be more relaxing and it is less painful in the water. These birthing tubs are brought into the home for a home bath, home birth also. Now there are various water birthing centers which have come up. Like previously it was in abroad in Western countries where they were concentrating and they were using this. But now even in India we can see that hello? Hello? Ma'am, next slide, please. Ma'am, next slide, please. Okay. In this, no. In this, you can find that whenever we are speaking about water birthing, as I said, these are the tubs which are available. These are specially made for water birthing process. And then these tubs. Hello? Hello?
Yes, ma'am.
Yes. There are so many disturbances today. So in this, we say that for preparation of water birth method, definitely there's so much of disturbance. So in this method of just preparation for water birthing method, you can find that the mother, she goes all the stages of birth in a portable tub, which is almost like a hot tub, as I said. And here, even if she wants to get out of the water and deliver the baby, she can do. And there are various positions which she can do. Also, you can see that this is done under monitoring. This is done under the supervision of experts person. And this is giving method like where it involves the immersion. And you can find that the immersion giving birth to the infant is also, it is an useful tool, and this is also helping in the labor process. Like in this, the preparation for water birth is like, they are already given proper training for water birthing. Moreover, there should be a written consent which has to be taken. And also you can find that there is a prior information about the status of the woman, whether it's a normal, like for abnormal or complicated cases, water birthing process is not permitted. And also in case during the course of water birthing, if at all any complications arise, they should be prepared for that, or maybe a cesarean section or any other way of delivering. Next slide, please. So there are certain benefits of water birthing. What you can see mainly, this is less painful. It gives a lot of relaxation to the mother or the woman, and it allows the woman to have a comfort in a way of various positions, and she feels natural and she feels less painful. It is like sitting in a warm tub water, and then also the partner or her companion who is there, they can help her out, get into the tub and support her. Also, they can see that you can find that there will be a larger expanded womb because she takes the position in the water. Also, it will help in easing pain. Also, you can find there will be speed of labor, or there will be a faster labor. Next slide, please. There are certain disadvantages of water birth. Some critics say that this may increase the risk of infection. And now, even though there are so many precautions and measures which are taken to maintain the cleanliness and the hygiene of the tank and all other things, but there are certain things where they say that they don't want to take any risk related to it. Also, you can find that if they are in the birth center, and where there are established tubs and all other things, there are many precautions which they are taken there. So if they are maintained there, that is good. Or many times, like, there can be like wrong things can happen if they are not maintained and if they are not taken care of. Also, you can find if the birth at home does not progress normally, it may require hospital or transport. As I said, like right now, what we are seeing is abroad countries, they do it in the home setting also. And we are having various centers which are done under supervision, where there are experts related to this, and even the pediatrician is available for taking care of the baby during the water birth method. There are like certain conflicting studies are there about the various risks and benefits. Some say this is good, some say this is not good for that. Next slide, please. Also, if you see, there are certain complications. If you have to see, water birth means sitting, pushing, delivering in a tub, which often sometimes there are chances like fetus can be passed out in the tub, or some say that this is risk for the baby, or if it takes in water. Also, sometimes there are risk of drowning or maybe aspiration of water. Next slide, please. Now, that was about water birthing. The other technique which nowadays, which is being mainly used, is about the Alexander technique. Here in this like here, if you deal, F. Matthias Alexander, he from 1869 to 1955, he worked for this Alexander technique. He mainly wanted to solve out his own vocal problems, what he had. And in this technique, we are like teaching about the sitting, standing, or moving with safety. The idea in Alexander technique is basically that if poor posture is there, that will give rise to a lot of health problems. So our main intention is like, we want the mothers to move about, and they should avoid stagnated into any one place. They can learn to release muscular tension to increase the breathing capacity and restores the body's original pose and proper posture. Next slide, please. So basically, they want to see the posture of the body has to be maintained. In this technique, you can find that there is a strategy for improving movement, balance, coordination, and flexibility. That's what I said. So this technique is mainly given for like pregnant mothers, and even other individuals can also practice here. And it will help in, it will be very useful for during the pushing. It will lessen the discomfort. And also you can find that this pregnant women, they choose to take weekly lessons related to this. Alexander technique also has various lectures, which classes which have been taken up. Next slide, please. If you have to see Alexander technique, as I said, there is a lot of movement here. Mainly, it is like your body begins to experience lower, like those 2 points are not put up there properly. So here I would like to say that basically here you can find it will balance your body structure, and it will reduce the digestive problems. Also, you can find it will prevent the shortness of birth, and there you can find mainly it will improve in the mobility, posture, performance, alertness, and it will give the relief of stiffness, tension, and stress for the mother. Also, you can find in this Alexander method, it will give a lot of coordination between the nervous system, the muscular system, and the skeletal system. So when all these systems and all this works up, definitely it is going to help for the mother's body posture and for her movement, and she's not going to have any stiffness, or flexibility can be encouraged, which will definitely help her during the birthing process. Next slide, please. So that was one of the methods which we saw. The next technique which I would like to tell about is hypnobirthing. In this, like in 1940s, if you see, Dr. Grantley Dick, he pioneered the use of hypnosis during labor to bring a woman into a state of total relaxation. Now, initially, we never thought that this could be used into it, but now we can see that her body's muscles, they can function according to the way she wants, and simple ways, like it is like self-hypnosis. It's a technique which can be achieved for a healthy and natural birthing process. It is also sometimes referred as a Morgan method of birthing. Here you can find the importance of hypnosis. Next slide, please. In this, you can find that the mother, she needs to learn this technique of self-hypnosis, or trying to get into her mind like what she is for, and concentrating on her birth and trying to have a positive response towards it. There are certain techniques of hypnobirthing, if you were to see, mainly as I told you about the deep birthing. Then there is various deep breathing exercises which she can do. Then also about visualization. She has to visualize a positive picture in her mind, and about creative thing, that things are going on, happening in very way. She can visualize about her child. She can visualize about the positive things, aspects of a birthing process. Also, you can say the mother here in the form of hypnobirthing, she can say positive affirmations. As we know, this will really boost her morale. They will help her that there is a spiritual feeling with her. And also she will say that it is like self-motivating. She will say, I can do it. I am strong at it. Nothing can stop me. I'm going to have a safe baby. So all those positive things, my child is a blessed child. So all this like self-hypnosis will definitely help her for the hypnobirthing. About mindfulness, like there should be relaxation of the mind. She has to see that she is to be without stress-free. And also in this, she can keep like certain small muscle relaxation techniques which can be followed, which will definitely help her for hypnobirthing. Next, please. So as I was telling, hypnosis, basically this is a benefit of hypnosis for the mothers. They can say, as they try to follow these techniques or try to follow the various methods in how they could go about hypnobirthing, it is definitely going to be of a great advantage. Next slide, ma'am. Next slide, please. So as I said, what can be the benefits of hypnosis or hypnobirthing? It will shorten the first stage of labor. It will lessen the need for interventions, or you can find this is a natural way of managing the pain by the mother. It will give a feeling of control over herself. Then she can think of she will be able to control her own thought process. She will also be due to which she can result in a healthy baby, and this will help to the mother mainly who has had a bad experience of trauma, or if there is a negative thought which is there. Because of this, you can find it will definitely help her for a positive birthing process. Next slide, please. So there are many topics which you can concentrate here in the classes of hypnobirthing is about pre-birth parenting, and then consciousness about the pre-birth, then about the parenting, and consciousness about the unborn baby. They can think about it. Also, there are 2.5 to 3 hours of sessions which is taken place. And in this, you can find what philosophy the mother has towards herself regarding her fear of childbirth, physical pain, those negative feelings, all that to be removed, so that this is going to help her for a positive childbirth process. So next slide, please. So like this were the few of the methods which we are using for the delivery methods, what you can find. Along with this, as we said, there are various alternative methods which are being used, which is going to help in the faster progress of labor. Like as Sir said in the morning, like there are various other alternative or complementary therapies. Initially, if you were to ask me, like when in the beginning, when PG students and all, they used to come to us for research problem statements related to alternative or complementary, we used to like refuse. We used to concentrate on the other methods. But now, as per the need of the hour, we are permitting, and you can find that there are many more studies which are carried on the various alternative methods or the techniques which can be used, and they are proved that they are helpful for the birthing process. Like, you know, music therapy, there are so much of research studies which are done, then about the acupressure, then acupuncture. These are the various alternative methods which are definitely going to help for the smooth and a safe and a faster birthing process. So that was all about the some of the methods. Now, when I was just surfing, like my previous slide, so you can find that we used to say that this advanced methods are used in Western countries, in abroad countries only, and still it lacks in India. But if you go and check out, there are so many organizations in India where you can find, to mention a few of them, I have just mentioned here, but there are many more which are there, which are offering this advanced methods like water birthing, Lamez method, Alexander technique, hypnobirthing, all this, like few to name a few. Fernandez Hospital, then we have hospitals at Delhi, then we have at Chennai, then Kochi, Bangalore, Goa, Pune, Maharashtra, and Mumbai, and at Madhya Pradesh, and many other places are there. So there are addresses and all the things are available on the net. You can definitely refer your clients, you can refer the mothers and make their knowledge clear about this concept related to the advanced methods of delivery. Next slide, ma'am. So without forgetting, like, you know, even though we think of this, rather than that, you should always know that when everything fails off, when the other methods are not applied and we are not able to, main concentration is on the vaginal delivery. But if things don't work up, and in spite of doing various measures and things are not working up, and for the need of the, for the protection of the baby and the mother, we need to take sometimes the decision of cesarean section or the surgical delivery, which is very common, which we all see. Like, you know, I was just going through it like this. The name is derived from the Latin word ceder, which means to cut. And that is how the name of cesarean section is there. We can know that we know the definition like a surgical opening, which is done on the abdominal in order to remove the baby. And next slide, we can find the cesarean section. Ma'am, next slide, please. We can find that cesarean section is still on the high. Here, as we said, like in the previous speaker, he said about the various measures or analgesia and anesthesia during labor and all other ways. So still people are preferring for cesarean section, and like they feel like this is the easiest way where they can be, they can opt for it, and definitely it can help them. Like the incidence of cesarean section is drastically increasing day by day. Next slide, ma'am. We know that there are two types of cesarean sections, that is elective cesarean section and the selective, like whatever is the emergency, and the elective cesarean section according to need of the hour, that will be taken off. Next slide, ma'am. You can find there are, I think I'm running out of time. So you can find that there are various maternal indications, and we all are aware about cesarean section. So I don't think so we should be like, I'll just go rush through it. So it's like contracted pelvis or previous cesarean section, or certain pelvic tumors are there, or any antepartum hemorrhage or hypertensive disorders or high risk cases or whatever we say. So in that cases, definitely there is an indication, maternal indication for the decision of cesarean section. Next slide, ma'am. There are certain fetal indications where the decision has to be taken, like malpresentations and malpositions, then prolapsed cord, or in case of any complications to the mother, or bad obstetrical history, or if there is a history of previous cesarean section also, that also needs to be taken. There are certain contraindications you can find, like many times when there is a dead fetus, we try to induce in the other way, or if there is a disseminated intravascular coalition, to minimize the blood loss, we go for it. And extensive scar or pyogenic infections in the abdominal wall, that can be there due to certain burns, or if they are not taken care of. Next slide, please, ma'am. There are definitely benefits, like here you can see benefits of C-section. Here the choice is between induced and having a cesarean section, and people feel that this is easier rather than going for those other bentos or forceps and other ways. And nowadays people or mothers prefer for cesarean section, and it is also decided as per the need of the emergency what has occurred. The decision of cesarean section will be taken. Next slide, ma'am. So there can be certain disadvantages, because like we are making an incision in the abdomen, so there are chances of infection or fever can be there. The pain can get worsened. There will be chances of increased vaginal bleeding. You can find there can be redness, as I said, at the site of incision site, or you can find there can be pain. Also foul smelling and vaginal discharge can be there, and pain while urinating, to mention a few of this. There will be certain complications during the C-section, which you should know, that bleeding from vagina or breathing problems for the child if they are not taken before 39 weeks of pregnancy, if they are not taken early. Also, there are risk for future pregnancies, because always in vaginal deliveries we say it is safer, and it is safe for the future pregnancies. Infection in the incision site, injury to the child during surgery, and various other things. Next slide, ma'am. Next slide, please. So like after hearing about the cesarean section, you should know, like we had that concept in our mind that cesarean section is the last way, like a mother can go and then she can't come back to her vaginal birth, or she can't go and opt for any other method of labor. So now there is a trend, like we have seen that after cesarean section also there are mothers who are going for a regular vaginal birthing process, and they are delivering with a proper vaginal birth even after cesarean section. Next, ma'am. So like there are many research studies which I came across, but here I just would like to say I was trying to think about the students' point of view, and then I found that there is a research here mainly which is done on the medical students in Saudi, where it says regarding the assessment of knowledge about water birth, and it is seen in the study like there were 235 sample size. And next slide, you can find that they have found that the students were lacking about the water birthing process, or the type of water birthing, and also they are interested, then too they are interested in this, and they would like to see that more labor, more birthing takes place with the method of water birthing. Next, so in this also there are other studies what you can see there, where they are saying hypnotherapy or hypnobirthing is a very important way, where there can be the mother is in control and she herself can take the decision of trying to how she can modify or modulate herself towards the birthing process of into it. So like to sum up whatever we have studied today or we have seen in today's topic, like, you know, it is mainly is also known as labor and delivery, and advanced, as I said, it's a childbirth. And we always encourage for the normal vaginal birth process. Then we should always be prepared for the cesarean section if there are any complications. And now we need to mainly encourage for the advanced methods which are painless and which are like, you know, without medications, which can be taught to the mother well in advance. And we can see there can be lesser vaginal complications during the vaginal birth. And that is what is our motto of this topic, which has been told, that we as nurses, we need to be aware about what is our role into this advanced methods, whether we are well trained for this, whether we are having adequate knowledge for this. And also we have to teach our clients related to this so that they will be able to have a safe birthing and a safe delivery process. So that is what I have for today from my side. If anything, please let us know. And thank you for all your cooperation. And once again, sorry for the technical problem which we had. Yes, ma'am. Next slide. Next slide. These are some of the references. Then you can also find the next slide, ma'am. There are various videos which are available, but due to time constraint, I was not able to show, but you could go and just see, because this was just an introduction of these methods. You could definitely go and make yourself more knowledgeable with these techniques and get yourselves educated with this. Once again, I would like to thank Dinsha Patel College of Nursing for giving this wonderful opportunity. And once again, sorry for the technical glitch which we had. Over to you, ma'am. Thank you.
Thank you, ma'am. And sorry for technical hurdles. But it was a very wonderful session, ma'am. If anyone wants to ask question, please they can ask. Okay. Thank you, ma'am.
Thank you so much.
Thank you, ma'am, for taking the time for this conference and making this event interesting. Thank you so much, ma'am. Now I invite Mrs. Mansi Patel for next session.
बस आज को मामा आपका नाम
आज पेलू डायग्राम आप
Hello, ma'am. Hello, ma'am. Are you there? Hello, Mansi, ma'am. Are you there?
Yeah, I am there.
Madam, within few minutes we will start our next session.
Okay, ma'am.
Slide from our side. Is that okay for you, ma'am?
Okay, ma'am. Please share my slides.
Good afternoon, everyone. I, Mansi Patel, Assistant Professor, OBG Department, Dinsha Patel College of Nursing. Once again, I welcome you all on this today's e-conference. As we all know, after delivery of baby, woman's body need to be recovered for 6 weeks, and sometimes they may get certain complications which will interfere with the normal puerperium, or we can say postpartum recovery. So here is the ma'am to guide us how a mother get quick postnatal recovery. Before starting her presentation, we will have some glimpse of her career in nursing profession.
I would like to introduce our today's present resource person, Dr. Mansi Chaudhary ma'am, Associate Professor, HOD Obstetrics and Gynecological Nursing Department, Sri Aurobindo Institute of Medical Sciences, Indore. I welcome you, ma'am. Ma'am has completed her PhD in the year of 2020 from JJT University.
Thank you so much, ma'am. Can I start my session?
Yes, ma'am. Over to you.
Please share my slides, ma'am.
Sure, ma'am.
Okay, good afternoon to all. Today's topic is quick postnatal recovery. Presented myself, Dr. Mansi Chaudhary. Particularly nowadays, many complications are arises, more increases nowadays. Main cause is postnatal recovery. Particularly in 1 year post-birth, reducing maternal mortality rates with the help of good mental health, domestic abuses, avoid, and postnatal recovery. Postnatal recovery and seeking support, mainly 3 points are included. Next slide, please. Excuse me, my voice is audible?
Yes, ma'am.
Okay. Next slide. Postnatal recovery and seeking support. In this, mainly 3 points are included. First is sexual dysfunction, pain, fear, intimacy, and incontinence. Many postnatal women sometimes
Madam, is it visible? Madam, you are muted.
next slide, please. My voice is audible.
Yes, ma'am.
Next slide. Introduction. Okay. Postpartum recovery. Postpartum is a one type of period. After that third stage, completion of third stage of labor, then start postpartum period. Postpartum period is mainly 6 weeks, 6 to 8 weeks period, or it can say 1.5 months. These times, all organs are revert back in pre-pregnant stage. During this time, hormones are fluctuated, thinking process may get hampered, and postnatal mother seems more emotional. During the first 6 weeks, postnatal mothers may pay attention on her body, must focus on baby and notice the bodily changes, which is very important for early recovery and quick recovery for postnatal mothers. Excuse me, next slide. Next, definition of normal perfurium. Perfurium and postpartum period is the same things. After that childbirth, 6 weeks period is a postpartum period or perfurium period, or it also gets partition periods. It's 42 days, first 24 hours, and early period is up to 7 days, and remote period is up to 6 weeks. Some points are to be remembered. Prevention of sepsis at placental sites, newborn care. Immediate newborn care is very important for baby. Next. Yeah. Then initiation of breastfeeding. After the second stage of labor, जैसे baby delivered होता है, then with the help of breast crawl method, initiate immediate breastfeeding concept. This can help for prevention of postpartum hemorrhage and easily separation and expulsion of the placenta. This is very important for baby and mother, both initiation of breastfeeding concept and role of postnatal exercise. Postnatal exercise with the help of muscle relaxation techniques and also help in revert back all organs. Then physiological changes and other genital tract many changes after that postnatal period, changes in breast and lactations, changes in other systems like fatigue, pulse slow hoti hai, temperature up and down, shivering. Sometimes patient can say shivering, fever up to first 24 hours after delivery, diuresis. It means more pressure on and more increases of urine, second to fifth day of postnatal delivery. Then postnatal checkup. Postnatal checkup is very important for mother, detection of high risk and earlier stage, how to manage the early complications like postpartum hemorrhage is a third stage complication. It means postpartum hemorrhage after that delivery, more than 500 ml blood loss. It can also say postpartum hemorrhage. Management of normal purpurium period, how to manage. Treatment of minor elements, it means breast engorgement, lactation is not properly, separation, treatment of anemia, health and nutrition education, and postnatal exercise. First point is postnatal care. According to care provided to the mother following pertussions, certain things must be kept in mind. The physician proceed with the postnatal care. First is general condition of the patient. First, to assess general condition of the patient, it means patient is febrile, afebrile, check vital sign, pulse, BP, temperature, respiratory rate. Sometimes patient also say pain in lower backache and lower abdominal pain. Then pallor, skin color changes, edema, dehydration. After delivery, more than 500 ml blood loss in normal delivery, it can say postpartum hemorrhage. Many types of patients is fluid loss, dehydrations, and after delivery fundus height. Height following pertussions and feel of the fundus is with the help of abdominal examination, decrease how much fundal height below than umbilicus area. If an episiotomy or C-section was performed, check the dressing area. Dressing is intact, any oozing secretions, pus, hematoma. Then lochia period. After delivery, third stage of labor, lochia is a symptoms arises in the patients. It may discharge of the blood, different type of blood. Lochia is a 3 types. Lochia rubra, starting 5 days, red color discharge, RBCs discharge. Then lochia alba and lochia cirrhosa. During this time, check the pets, how many pets women are changed in a day, like color, amount, order, any foul smell, with the help of radar scale. Then bladder, patient catheterized for 12 hours following local anesthesia during C-sections, 24 to 48 hours after general anesthesia, and check the bladder and bowel functions. Follow with the neonate and check baby conditions. Next is changes in breast and lactation. जैसे बेबी डिलीवर्ड होता है, बेबी को एक हेल्प चाहिए रहती है, बेबी का फूड जो भी होता है वो मदर के थ्रू मिलता है. तो ब्रेस्ट फीडिंग इज वेरी इंपॉर्टेंट फॉर बेबी. एंड changes, many changes in breast and lactation. First is mammogenesis. Mammogenesis, it means mammary duct gland growth and developments. Lactogenesis, initiation of milk secretion in the alveoli. And galactopoiesis, maintenance of lactation. And galactokinase, removal of milk from the gland. During this lactation cycle, breastfeeding is very important for newborn and neonate. Breastfeeding, first concept is proper latch on. मतलब बेबी कैसे फीड कर रहा है. अगर प्रॉपरली बेबी फीड नहीं कर पाएगा, प्रॉपरली पोजीशंस नहीं होगी, तो फीडिंग में प्रॉब्लम्स होंगी. तो फर्स्ट यू लर्न बेबी ओपन द माउथ वाइडर, chin touching the breast, cheek looked flattened, lips are flat out, the breast looked full and round. It means black alveolar portion is full in the mouth. Baby can hear the sound suck and swallow. Nipple looked long and round after breastfeed. One picture also shows mouth cover alveolar area and lips are flattened out. It means baby properly suck the breast. And during this breastfeeding, positions are very important. First is cradle positions. Next is cross cradle position. Already pictures can show. Football and clutching position. Football position is very helpful for twins pregnancies. And sideline positions. After that, सी सेक्शन मदर्स के लिए बहुत हेल्पफुल होती है, स्लाइडिंग साइडलाइन पोजीशंस. एंड नेक्स्ट इज आफ्टर फीडिंग. Rest is very important. Looking after a newborn baby is demanding feeding. It means postnatal woman body is also recover from the rigors of pregnancy and childbirth. If she is feeding at night, she may become exhausted and essential to rest. It may tempting to use the time when baby sleeps during the day to catch up with course. But it is important that she has sleep and take proper rest. It is very important for postnatal mother. Then coping with changes. How to coping with changes? Woman's life really will change dramatically because after that delivery, mother can care of newborn baby. Try not to have unrealistic expectation of yourselves. Then postnatal checkup. In postnatal checkup, first is general health checkup of the postnatal mothers. Then physical examination, head to foot. Then monitoring of evolution process. Very important thing in during postnatal period. यूट्रस जो है अपनी प्री प्रेग्नेंट स्टेज में जाता है. मेनली जो चेंजेस हमको देखने के लिए मिलते हैं वो रिप्रोडक्टिव सिस्टम और ब्रेस्ट में चेंजेस देखने के लिए मिलते हैं. तो इसमें क्या देखना है हमको, इवोल्यूशन ऑफ यूट्रस हो रहा है कि नहीं. जैसे ही बेबी डिलीवर्ड होता है बिलो देन अम्बिलिकस हार्डिंग मास फील होना चाहिए. यूट्रस और लोअर एब्डोमेन जो है फ्लैबी होना चाहिए, थीन होना चाहिए. इन केस अगर हमको हार्डनिंग फील हो रही है, बहुत ज्यादा उभरा हुआ नजर आ रहा है, फंडल हाइट मोर देन इंक्रीज्ड, इट hours बेबी को फिट कराना इज वेरी नेसेसरी फॉर एग्जामिनेशन ऑफ न्यूबॉर्न. इमीडिएट न्यूबॉर्न केयर में एग्जामिनेशन करना है, अवगार स्कोर चेक करना है 1 मिनट इन 5 मिनट. बेबी का सकिंग रिफ्लेक्स कैसा है, कैसे प्रेजेंट है, बेबी का स्किन कलर, टोन, रिफ्लेक्सेस एक्सेट्रा. मैनेजमेंट ऑफ नॉर्मल परफ्यूरियम. हाउ टू मैनेज नॉर्मल परफ्यूरियम? First are important for PPH. PPH is a complication of third stage of labor. Third stage of labor, it means separation and expulsion of the placenta. During this time, in normal delivery, more than 500 ml blood loss, it may also known as postpartum hemorrhage. In case of this condition, fluid electrolytes balance करना है, IV fluids देना है, more than 500-600 ml अगर blood loss हो रहा है तो blood हमको मदर को देना है. मदर का HB लेवल चेक करना है, उस चीज का हमको ध्यान रखना है, रिकवर करना है पेशेंट को. एंड कोगुलेंट्स ड्रग्स देना है मदर को, लाइक ट्रेनेक्सा, इथामसाइलेट, मिथार्जिन, ये सब हम ड्रग्स देंगे. पेशेंट को ये देखना है कि व्हाट आर कॉज ऑफ PPH, लाइक एनी कॉटलीडॉन्स और लोब्स इनसाइड इन द यूट्रस. देन with the help of squash and Duquesne method, remove the all placental parts. Then early ambulation after then normal delivery or C-section. Postnatal mother will help for early ambulation. Avoid strenuous activity for 6 weeks during after delivery. 8 to 10 hours sleep and 2 hours rest in afternoon. Needs more than 300 kilocalorie increased in your postnatal mother diet. During antenatal period, daily 2,300 kilocalorie are intake, but in lactation period, need more than plus 300 kilocalories. Care of nipple and alveolar area during feeding or after feeding. Clean the breast with normal water, normal saline. Then feed the baby. Treatment of minor ailments like after birth pain, particular in backache, lower abdominal pains, and pelvic girdle pain after the delivery. Seize bath is very important for episiotomy patients. Some exercise is very important. Then retention of urine. First, second to fifth day, retention of urine are increased. Pain at the site of perineum area. ड्यूरिंग फीडिंग, अगर मदर सिटिंग पोजीशन में देती है, फीड कराती है बेबी को, तो पेन ज्यादा फील करती है, तो उसके लिए हमको काउंसिल करना है मदर को कि अदर पोजीशंस ऑफ कैन आल्सो यूज्ड फॉर फीडिंग. Engorgement of breast. Sometimes preterm baby are not properly sucking, reflex are not proper. These problems are also caused engorgement of the breast. During the breast engorgement, apply hot applications, remove the milk, and properly feed the baby. Treatment of anemia. Then breast problems, particular during postnatal mothers, we can see breast problems like retracted and cracked nipples. Retracted and cracked nipples, जो मदर का फीड होता है, अगर वही मिल्क हम सोर निपल्स वगैरह पे यूज करते हैं तो उसमें एक प्रॉपर्टी होती है हीलिंग प्रॉपर्टीज, जो कि मदर के लिए हेल्पफुल है. So then apply the एलोवेरा एंड cracked nipple mother feed milk. Breast engorgement, mastitis, infection in the breast and breast abscess. During breast abscess, not feed the baby. Failure of lactations. Next, puerperal psychosis. During postpartum period or puerperium period, mainly 3 psychological complications are seen: puerperal psychosis, puerperal depression, postpartum bluish. During this transit period, self-limiting period, sometimes couples are not coping with the baby and preterm baby conditions, like baby NICU में है तो मदर उस चीज को कॉप नहीं कर पाती. इस टाइम में ये सब कंडीशंस हमको देखने के लिए मिलती हैं. तो management of these conditions, antidepressant and psychological counseling for the mothers, postnatal mother and couple also. Next is obstetrical palsy. Obstetric palsy, severe neuralgia due to pressure on the lumbar sacro nerve plexus during the C-section and pain-free delivery. Mainly these conditions are seen. Foot drops, rarely femoral obturator or sciatic nerves may be involved in these conditions. Spontaneous recovery usually, and physiotherapy is very helpful for obstetrical palsy. When to see a doctor? Heavy vaginal bleeding that soak more than 1 pad per hour, or vaginal bleeding that increase each day instead of decreasing. After that, third stage of labor completion, apply the pad on most postnatal mother perineal area. Pre-padded study, हम लोग जिसको बोलते हैं pads की study करते हैं. How many pads are women in daily change? Puerperal pyrexia, puerperal sepsis. During puerperium period, all organs are not revert back in this time. Sometimes foul spell in lochia. This also can cause infection in the puerperium period. Puerperal sepsis and puerperal pyrexia. Vision changes or a severe headache. During this vision changes or severe headache, particularly in high risk during pregnancy and eclampsia mothers, painful urination or difficulty in urinating, vaginal discharge with a strong odor in infectious puerperium period, heart palpitations, chest pain or difficulty in breathing, vomiting, incision from C-section or episiotomy site is red, VP with pus or swollen edematous reddish color skin in perineal area particular or C-section site. Abdominal, lower back pain, lower belly pain, sore breast that are red or feel hot to touch during the examination, pain in legs with redness or swelling, increase in swelling in lower extremities particularly. Then next point is very important during quick postnatal recovery is very important. Postnatal exercise. Many type of postnatal exercise during postnatal recovery. First is Kegel exercise, boot exercise, pelvic tilting exercise, abdominal exercise, squats, breathing exercise, etc. Benefits of exercise. First is reduce the risk of developing heart disease, diabetic and cancers. Reduce high blood pressure, high cholesterol in the postnatal mothers. Reduce body weight, depression, anxiety, improve psychological well-being plus mind stability, builds and maintain healthy muscles, bones and joints. First is pelvic floor exercise. Pelvic floor exercise is a Kegel exercise. Contract your pelvic floor muscles for 3 seconds and then relax the muscles of 3 seconds. Do this 10 to 15 times several times a day. Although shown here while lying down, this exercise can be done during a variety of daily activities such as sitting in a meeting, while stopped in your car at a traffic light, or when talking on the position is not necessary. This exercise can also done in sitting position also. Next is pelvic tilting exercises. These types can also use pelvic rocking exercise. Next, deep breathing exercise. Deep breathing with knee bend, with a pillow and behind. Breathe is deeply through nose and side out. Repeat 5 times in a day. Hip hitching or leg shortening exercise. Hip hitching and leg shortening exercise, lying in the back with one knee bent and other knee straight. Alternately, this can done, slide the heel of the straight leg downwards, thus lengthening the leg. Shorten the same leg by drawing the hip up towards the ribs on the same side. Next is foot and leg exercise. Sitting in a proper position, foot and ankle exercise can done 10 times each directions, rotate circular proper manner. Stretch your ankle for 30 seconds. Repeat this exercise frequently. Next is postnatal diet. During lactation mother postnatal period, diet is very important for mother and baby. So that can use healthy diet. When planning your meal during the breastfeeding phase, ensure that you are including a variety of foods, just the right amount of calorie and fat. You should make it a point to include items from the 5 main foods categories like green leafy vegetables, fruits, citrus fruits, cereals, pulses, healthy diet. Milk and dairy products, eat or drink moderate amount and choose lower fat versions foods, dairy foods, fruits and vegetables, including fresh, frozen and tinned varieties, salad, vegetables, beans, lentils, dried foods and fruit juices. This can proportionate 5 proportion a day. Meat, fish, and alternative. Alternative includes like egg, beans, and lentils, nuts, vegetables, more rich diet in protein. Then water is very important for postnatal mother. It is also important to consume copious amount of water to prevent dehydration. Keep your milk supply and fruit juices can also choose for some variations. Then fruit containing fat and sugars. Eat springly, infrequent, and in small amount food containing sugar and fats. Then health education for quick postnatal recovery mothers. First is postpartum checkup up to 6 weeks later. Problem to be reported to physician in the postpartum period, like heavy blood flow, gush of bloods, any foul smell during urinating. Method of contraception, how is a natural contraceptive 6 weeks, no use of any choose contraceptive methods or devices. Physiology of puerperium period, it means revert back to all organs in the pre-pregnant stage, and return of menstrual cycle, how much days. Diet of lactating mother plus 300 kilocalorie in a day. And breastfeeding the mother, breastfeed how many times, demanding feedings to give in newborn babies. Immunization for the baby, management of minor newborn problems, care of eye and umbilical cord, diet in postpartum period for a lactation. Encourage women to do things for themselves that they enjoy, such as meeting up friends, getting out of the home and walking, or things which help them to let their feelings out, like singing, drawing, writing, any hobbies you can do. Spiritual reliefs through prayers, meditation, yoga. Support the woman in whatever you can. This may include a home visit, extra postpartum appointments. Encourage her partner and family members to support their postnatal mothers practically and emotionally. It's very important for quick postnatal recovery. Thank you so much.
Thank you, ma'am.
Hello, everyone.
Thank you, ma'am. Now moving toward, if anybody have any question, they may ask or they can message in chat box. Thank you so much, ma'am. There is no any
Any
question
doubt from the
from
student side? Actually, ma'am, my topic is very fast running.
Yes, it's okay, ma'am. No problem. Thank you, ma'am, for your valuable words. Moving towards our valedictory session, I would like to hand over Mrs. Dhara Vyas, ma'am, HOD from Child Health Nursing, to propose the vote of thanks. Thank you, everyone. Thank you, ma'am.
Thank you so much, ma'am, and Dinsha Patel College of Nursing for giving this opportunity to me as a resource person. Thank you so much. Thanks.
Thank you, ma'am.
Good evening, everyone. First of all, we have shared a feedback link into chat box. Kindly fill it, and it will be open up to 5 p.m. Good evening to all respected dignitaries and delegates. It is my privilege to present the vote of thanks of this e-conference on exploring the advanced practices in maternity organized by IQAC and OBG department. First, I am heartily thankful to management of Mahagujarat Medical Society for providing auditorium and facilitating the conference with constant support and not taking any registration fee from any delegates. I would like to convey my sincere gratitude to Dr. B.H. Shelat sir, Director of Dinsha Patel College of Nursing. I am indeed grateful to you, sir, for your continuous guidance and enormous support as the backbone of the conference. Thank you, sir. I would like to express my profound gratitude to Mrs. Ami Menon, Lecturer Class 2 Genera, Mr. Himanshu, Associate Professor, Nursing Superintendent, College of Nursing, AIMS, Jodhpur, Mrs. Martha Raut, Associate Professor, Dr. D.Y. Patil, College of Nursing, Pune, Dr. Mansi Chaudhary, Associate Professor, Head of the Department, SAMES Nursing College, Indore, for sparing the time from a busy schedule and accepting our invitation to share your knowledge and to be a part of the conference. Thank you, sir and madam. I'd like to express our sincere thanks to our principal, sir, Professor Virendra Kumar Jain, organizing chairman of the conference and giving logistic coverage in the planning and organization of the conference. Thank you, sir. I would like to convey my sincere thanks to Mrs. Arpita Vaidya Madam, Vice Principal DPCN, to the kind guidance and support to make this conference successful. I am thankful to Mrs. Neha Parmar, Organizing Secretary, Assistant Professor and HOD OBG Department, for a tremendous tireless efforts to make this conference successful. Here I would like to thank OBG department members for their absolute support. I am also thankful to all moderators for hosting the session. I must mention a hearty thanks to all nursing family and for the excellent response. I must mention there is a huge response from delegates, more than 750 registration. Great response from the overseas like Australia, New Zealand, Canada, Nepal, Sri Lanka, UK. A big thanks to all the delegates. I would like to thank all organizing committee members, non-teaching staff, students. Without your participation and great support, this conference cannot achieve a high standards of success. My special thanks to technical committee for making this conference on a virtual mode. I thank everyone who has contributed to make this conference successful one. Thank you one and all. Once again, thank you. Jai Hind, Jai Bharat. If anyone want to ask anything or give any feedback regarding this conference, so please from Zoom participants. You can unmute yourself and share your experience.
Anyone wants to speak from the participant? Okay, so we will end up the meeting over here. Thank you so much.